they are honest, we can classify food down into the storm. This happens because this happens because that we are trying to compress the dilated esophagus between the body of stomach and the body of stomach anteriorly and the thoracic area posteriorly. And this is increasing the pressure in the esophagus and therefore food goes down to the stomach. But there is no such relationship between factors. Typically, lower dysphagia patient, they have a long durations in years, whereas in mechanical dysphagia, you get a short history. It is only esophageal chest pain is very suggestive of more dysphagia and usually mechanical dysphagia pain. The regurgitation of the food, that is effortlessly coming out of the mouth, is very suggestive of more dysphagia. In fact, it suggests that the esophagus of that patient is dilated and there is decompensation of upper esophageal sphincter to prevent regurgitation. Whereas in mechanical dysphagia patient, due to esophageal cancer or due to epileptic stricture, regurgitation is small, and weight loss is minimal or none in patients with motor dysphagia, whereas it may be there in mechanical dysphagia. So this is how you make the history in your team. But many a time when we are sitting in the clinic, we are forget to do an important examination. Ask the patient to swallow in front of and see what happens. Now this is a very important component of the examination which is missed in that. Now I go further how to approach this patient. Just look at the patient that is dysphagia and you look at the history as I told you do a physical examination. After that, you decide to do an endoscopy of the area. So typically, those who have endoscopy, very easily accessible, for example, Dr. Mahmoud or Dr. Kuna, they will quickly do an endoscopy and you will decide whether they are developing a patient of mechanical dysphagia or not. But if you are in the remote periphery southwest where you may not have endoscopy very easily accessible, you will have to be answer. Now, in endoscopy again, you find the solution. This is obviously it is a patient of mechanical dysphagia. On the other hand, if you do not find this picture, this is the patient of motor dysphagia. And you are asking for the spectrum of motor dysphagia. These are the two series of the series one on the left side has 200 patients progressing on the day, and there you can see the ectocyte constitutes
ऑडियो सब जल्दी आना चाहिए
and that kind of ectocyte is classified as ectocyte and visual sectors. Visual sector is the main recognition of contractility in the ectocyte. On the other hand, classic ectocyte means that the ectocyte is becoming and their organs contract. Other diseases that are rarely studied in the physics of the causing hypertension, and no pathology. So this was a series of small number of patients who understand published in 2010 and subsequently extended new art analyzed our data. And you can find in this 799 patients, quite a big number, and they are also the situation remains the same. Ectasia constitute majority of the feature in the What are the types of accounts and what is their approach? Normally, esophagus contracts like this. This is called peristaltic contraction. What is peristalsis? Peristalsis means when the upper part is contracted, the lower part is relaxed. And when this part is contracted, this part is relaxed. This is happening because esophagus in the upper part contract and lower part is to relax to receive the food. And this happens because there are two types of neurone in the esophagus. One is the excitatory neurone, which is extracellular containing neurone, and then are infiltrating neurone, which are containing neurone or nitric oxide containing neurone. And there is a gradient of the two, as you can see. The lower part of the esophageal muscle more containing neurone, which is immediately then the upper part, and this leads to progressive development. In accuracy of heterogenesis, what happens is there is a degeneration of remote in the initial stage so that this gradient is lost. And that leads to contraction with figures like this, which is like a non-sloping or simultaneous contraction. But as time goes on, actually what happens is that there is a volatile generation of foam and consequent surface, including the cholinergic mass, and this leads to inadequate contraction disorder, and this is a diameter disorder like this, sigmoid disorder like this. So what happens is there are typical stages of accuracy, which I will describe here. Now this is the kind of classification of symmetry. Now the symbolic classification was initiated by a man he was in Chicago, in University of Chicago, and he started so that systematically he classified all the social disorder. And I'm really pleased to let you know that with the work from India, the India is becoming more global, and least we are contributing to the world literature reasonably now. And you can see there are two people, Dr. Soma Bhatia from Mumbai and myself, are featuring in the city classification of Singapore. Now, what is the classification of Singapore is? Before I go to that, I want to first let you know what is the anatomy of motion. This is the esophagus, and food bolus is the intelligence. The moment food bolus enters into the esophagus, because it is like a closed cavity, there is increase in the esophageal pressure, and this is called intrabolus pressure. And as you can see here, the deep blue color here has become white. So this is a horizontal esophageal where the upper deep root suggests parental pressure. This part suggests upper esophageal sphincter pressure. This part suggests lower esophageal sphincter pressure. Beyond that is the intra-gastric pressure, and between the upper esophageal sphincter and lower esophageal sphincter, you are negative intra-gastric pressure. However, during the contraction, you get a positive esophageal muscle contraction pressure. And as you can see, the deep blue will become a particular blue here, and this is the intravenous pressure. Now, subsequently, the esophageal circular muscle contract about the roof, and this is called esophageal contractile form. This is a peristaltic activity, as you can see here very slow, and this high contraction pressure of the esophageal would expect or is expected to push the bolus down. But to let the bolus go down to the stomach, the lower esophageal sphincter has to relax, and this relaxation happens because of nitric oxide containing neurone, and therefore the relaxation of the lower esophageal pressure, there is very little residual pressure, relaxation, and this is called integrated relaxation. In relaxation is much more secure than start. So even there is a failure of contraction, like I said earlier, or there is a failure of relaxation, or if contraction is still a risk of this simultaneous, this leads to this failure or this failure. This is a complicated diagnostical classification before which I do not want to relate in all short time that we have. What I do typically can see on the left side there are calcium and on the right side non-calcium. Left side calcium are divided into calcium type 1, type 2, type 3. Type 1 is this is a flattening software, so therefore there is hardly contractility and ischemia. Look at this. There is hardly contractility. One is going to explain that there is an eye, one is going to explain that there is an eye, there is nothing in it, there is type 1 access. Hypercholesterolemia means yes, there is a contractility, but these are simultaneous. And this is the both of these softwares is having a simultaneous contraction that is a type 2 access. On the other hand, type 3 calcium means there is a segment of the software which is having a high contraction activity and simultaneous nature that is nitrogen gas. In addition, we can add several other sources that are non-calcium such as skin contractility, discharge particles from hypercontractile and effective sources which I want to hear about. Now, coming to the other software are very important investigation, and if you really concern about what I suggest to you, please start with the area of this page. What I do is refer to your area of if you want to know more about this, read this article that I published for a long time ago. Now, how to do an and radiation. Now, what I do is that you take 45% rate of medium, the fish after the share, you actually swallow in one go, and then simultaneously in one go, then what you see is that you take one thing, you find extra, and you see the root of the area and the height of the area in the area. What I would do is find to read this hard, particularly the human and find this suggests two possibilities and associated with our experts. Now, this is a very simple experiment. How to manage this person? Attach the person to the very simple procedure, but 1 to 2% patient can have prophecy, and one knows that the calcium response. Type 3 calcium response was to pneumatic calcium, type 2 calcium response is, and type 2 calcium response only. Now, this is one of the studies for media, which is one of the initial studies that show type 2 calcium response better than type 3, which is one of the initial. Now, another way that you manage the calcium is injecting botulinum toxin into the soil. Botulinum toxin injection is widely by dermatologists to actually reduce the bleeding the skin in the old age, but facility show that if you inject botulinum toxin into one soil, because it works to block cholinergic activity, it also treats patient like this. But what's the problem? Problem may be that if you treat this patient botulinum toxin, though 90 to 95% patient respond short term, but in 1 year almost 100% will get that. So, is there a place for botulinum toxin today? Hardly in place, but very clear. If you have a patient in whom such thing cannot be done because they are fully body brain fragmentation, now there is not to be done. Because 1 to 3% patient who have may have muscle changes and may require surgical backup to heal the balance of the so what we do is typical in this patient is inject toxin, improve their respiratory, improve their nutrition for regular food intake, and then later we improve their immunity. So I don't buy on time.
डायरेक्ट लग जाएगा मैकबुक पे क्या फिर लग जाएगा वहाँ पे डायरेक्ट हम लेके आए HDMI पे भेजे दो ना मेरे पास या फिर उसको इजेक्ट करके डिस्पेंस लेके देखो उसको इजेक्ट करो ठीक से इसको डाल के देखो
now, this is the problem. This is one of the
नहीं बात चलाना पड़ेगा आशीष का फिर के बाद में
also we can and in this time, if you can reduce areas to 50% from its baseline versus the other damage food balance. Subsequently, a prospective study, we found the base ratio that is associated with so usually we have reduced
shadows का जो भी है
we are below reduced to below 22.5
slide show mode में चले जाएंगे
now this is another study from
scroll कर लो
and what
वीडियो कुछ नहीं बस पिक्चर्स
after pneumatic and what is
सेशन आपको मालूम रहेगा मेरा रहेगा रिजेक्ट कर दीजिए रिजेक्ट करो
this foreign patient had more often than foreign. Now, he was asking if I do not a facility for suffering and can be done in the second or if someone says I want to, but I do not access to time in the second because my regular is going forward. So, this is a prospective study published in 1990 where the form is better than in assessing post-pneumatic balances. But we did a study to a prospective study. This one is a prospective study. Our one also analyzes this one is and we found and especially the analogy compared to assessors on frequent design for now, where is the immorality but the reason being, if you go what happens is almost 40 to 50% patient will develop severe gastroesophageal. So therefore, women's can be an ability to allow and not be balanced with more expensive, more softer, more complication, require more expertise, more medical recovery. So therefore, the medical balance is the cost of women in the subsequent. Thus, the next sources this is a study which suggested but we really criticize this study that they want to ignore with the fertility and subsequently repeat the study outside and inform this is recovered, not restored recovered, but severe recovered. So therefore, I believe that
अभी टॉप करने के बाद पता चला या अपलोड करने आइए यहाँ पर देख लेते हैं ISD रांची करके होगा जैसे प्रेजेंटेशन हुआ है पीपीटी वाला वीडियो अलग से भी हम रख लिया कि मान लीजिए अगर नहीं प्ले होगा तो हम हाँ पूरा फोल्डर डाल देना तो डाल दीजिए आप
performing, but let me tell you, both these things are reduced, but they will. These are the patient because the home of the for time of the patient not fit for surgery. We give water on toxin injection most of the time. 100 million. 25 million daily water in each one along the circumference of the areas, just about once between the GA and what happens is almost 80 to 90% of the recover and the recovery will last from 6 months. During that time, you can make the patient fit for surgery by taking the whole morbidity in whatever you might have. You can do it, you can do it.
Thank you very much, sir. It was very, very informative and everything, and to the patients. I think that is sir. That is yours.
Thank you. Hello. Thank you so much, sir, for such an informative session. We would like to felicitate you. We got the chairman to please come up to the dais and felicitate sir and all I know.
Thank you.
You really clear,
Yeah, thank you very much.
Now we like to felicitate the chairperson. So quickly moving on to the next session, we have the next speaker, Dr. Isgcon, and the chairperson to the same Dr. S.K. consultant gastroenterologist Patna, and Dr. Sanjeev Thakur sir, consultant gastroenterologist Patna.
सिग्नल चाहिए ना छोटा जैसा एगो पीला जैसा पाउच है उसमें हम आपका यहाँ लगा ये वाला मत ब्लू वाला इसे मेन स्ट्रीम ध्यान से इनपुट है तो गया सिग्नल यहाँ से जा रहा है चेक कर पहले से था पोजीशन नहीं जा सकता हम डायरेक्ट लगा दिया एकदम डायरेक्ट लगा है इसको फ्लड ये भी एकदम डायरेक्ट लगा है मुझे देखना है चलेगा सब वीडियो चल रहा है या नहीं वो चल रहा है इसको चलाने से
Can this concept find in large gastric ulcers?
Gastric reflux, actually, so doing the better option here, doing the better option in the primary basis is also revolution, gastric reflux. So doing better option here. And tomorrow gastric reflux is one large bunch of values. So do and here is not single bunch of these. There is a multiple bunch, three certain protein conjugates. So I guess small experiment is one better here. Maybe going to some we have many units there, because of such very slightly for breed and everything. So that's I don't have done.
Okay, so it's currently used to create the unit of biochemical certain values which are difficult to operate.
One therapy has been described for gastric reflux and abdominal values. It is only one therapy. But this lesion is very rare. So literature is not available here. Capital condition of is very rare lesion. So hardly once in a lifetime doing twice such a large lesion. So literature is not available. I think the answer would be same because gastric values is large layers of space to point but in this small it will be difficult for point.
Making it smaller is clearly for me and having a high volume injection. Other than avoiding a volume related complication that is key to what we do in sclerotherapy, any chances of stricture and sepsis.
So stricture and sepsis, these are the potential complications. So naturally we also afraid of that, but we follow the video policy. So follow also. Illegal ideally stricture illegal restriction can be possible.
Saving of time.
नहीं ये तो दूसरा साइड है
So reason
नीचे जाए ये नीचे ये मैं अपने लैपटॉप हाँ फिर ये सब करने का
Felicitation of the chairperson. Now we have the next speaker, Dr. Amit Kumar Datta, and the chairpersons for the same will be Dr. Vijay Prakash Sir, Professor and ex-HOD of Gastroenterology Department at PMCH Patna, and Director of Bigger Polo Spectra Patna. Dr. Saurabh Jaiswal, Consultant Gastroenterologist Patna, and Dr. Tej Narayan Sir, Consultant Gastroenterologist Patna.
His research areas are GI disorder, advanced endoscopy, and he's going to speak on a very difficult and controversial, the old controversial situation when it's very difficult to decide how to differentiate or differentiate features between Crohn's and tuberculosis. Dr. Please.
Thank you for the introduction. Good morning, everyone. And first of all, thank ISC for actually participating. Congrats on hosting such a wonderful meeting. So the topic of my presentation is differentiating epistemic tuberculosis from Crohn's disease. So we all know that frequency of Crohn's disease is actually an area which is more than Crohn's disease. And in fact, if you look at the population side of the country, absolute number of Crohn's may equal to what we have in say in the US. So just to make sure names and Crohn's and tuberculosis share significant endoscopic histopathological features, and sometimes it might be really difficult to distinguish Crohn's from tuberculosis. But at the same time, the treatment of BD is so different from Crohn's disease, we have to put in very effort to differentiate the two conditions. Therefore, differentiation is important for appropriate management. And if you follow a systematic approach, then up to now, 85 to 90% of cases you can distinguish Crohn's from BD if you follow a systematic stepwise approach. And that's what we will discuss in today's presentation. So the chronic inflammatory response which is mounted in BD and Crohn's have quite a bit of similarities. For example, in the paper from our center, Dr. Alex has shown that the cytokine gene expression profile is same in BD. So because of similarities in this chronic inflammatory response, we are seeing phenotypic similarities in terms of the endoscopy pathologies. So what is the magnitude of problem? How frequent and how common is this problem of differentiating BD from Crohn's? If you look at the early 90s, so the 90s actually, that time Crohn's was considered to be quite uncommon in the country. And at that time, about 50% of patients actually who had Crohn's were given ATP because they now have tuberculosis. So this is the data from North India, from AIDS and HCT and Calcutta, where I had 22 patients, of which 43% received ATP. So in that case, that was not clear. Another data from August 2013, we had 223 Crohn's patients, and about 30% of them had received ATP. So therefore, there was quite a significant misdiagnosis initially. But as time has gone by, the situation is improving. That's because there is improved awareness about Crohn's and we have better diagnostic facilities. Right now, despite the fact that still about 10 to 15% of cases still are not able to differentiate despite based on our efforts. So when we are not able to differentiate BD from Crohn's, what we do, we can differentiate. There are a few reports recently which are saying that if you get OTP, you also have harmful effects. For example, the study from Maine University showed that they had about 158 patients of BD and Crohn's, 79 of them diagnosis not clear, ATP received, other 79 no ATP versus clear diagnosis. So these patients who were actually Crohn's and they got OTP, in the remaining 26.6% are statistic. But on follow-up, the rate of symptom became about more than 50%. Whereas in the group which was correctly diagnosed, ATP not given, treated as Crohn's, the rate of structure saw a bit almost reaching 26.6 to 27%. So therefore, what they showed was that giving ATP regularly is somebody who has Crohn's, there is a higher risk of structure formation. And they also showed that there is a higher risk of surgery in Crohn's if you give them ATP. Similar data for advanced symptoms showed there is a higher risk of structure formation if you give ATP. This is the first instance for my as a patient that it can be difficult to differentiate Crohn's from BD. In some patients, you won't be able to differentiate, but we should put in every effort possible to differentiate BD from Crohn's so that we can avoid an harmful effect. And once you have done it systematically, you can't differentiate, then you will. Because everything you be very clearly without much investigation, it may have harmful effects. So how do we go about doing this differentiation of BD and Crohn's? As I told you, we have a stepwise approach, which includes looking at clinical features, methodology, colonoscopy findings,
voluntary and biological investigations. If you apply these steps properly, in 85% cases, you will be able to say the screening goes correctly. Still, about 10-20% you will not be able to diagnosis. So there are more than 40 studies in the literature which are looking at differentiating TB from clones, including studies from outside and etc. So what are the two things? One is that it is an important topic, and some studies are being done. Also, there are some products which are perfect, we can see that's why more and more studies are being done. So obviously, we always begin the process of investigating, looking at the clinical picture, the history and examination. We look for pictures like abdominal pain, etc. Good systemic, good form of gender and systemic examination. So what are the features, what are the clinical features which can tell you this is non-active reports or non-active reports? One of the most helpful feature is actually the duration of symptoms. If you look at the duration of symptoms, generally tuberculosis is around 6 to 18 months, whereas the clones it can be up to 5 years. So the long duration of symptoms generally is apart from duration of symptoms, there are other features as well. If you look at this graph, the orange color is really blue and orange bones. If you have fever, night sweat, ascites, pulmonary involvement, all that triggers tuberculosis. If you have malaria symptoms, extra-intestinal manifestations, bleeding for a this favor, but when you do another is actually individually these findings are not symptoms, malaria symptoms, DRIs, bleeding for rectal shorter duration of symptoms, ascites, night sweat, lungs and pulmonary symptoms, favors. Then we go on to the blood investigations, and blood investigations are good depending on the general condition of the patient, as well as genetic information about the CBC. These markers of inflammation are very helpful in differentiating TB from clones. Then we go on to serology. Now we will ask us something which is used to differentiate in the West, ulcerative colitis from Crohn's disease. But there are three studies in our country from our
म्यूट करने थे ये बते ना दोनों कर दिए
Simple chest X-ray can tell you about 50% but the imaging which is generally required is a cross-section imaging. This cross-section imaging is either a CT scan or MRI. One thing I want to wish this and this is that when you CT MRI, please ask for endodomy. The CCT is not because endodomy shows you the normal regions are much better. So often we see endodomy regions are not a CT scan, and then everybody number scan the radiation. So when you are imaging the clones, please ask for endodomy. Because that is the negative. So what are the features which differ Crohn's disease? Skin lesion, some lesion involved, some lesion not involved, skin lesion, long segment and the long segment involvement, hypertrophic inflammation and surgery, involvement of the mesenteric such injections, something like what is called as the home side. So we have skin lesion, long segment, those favors. Crohn's disease epidemic doesn't come out from the on the other hand, if you have necrotic tumors in your religion, or if you have ascites in your lymphocytic abnormality, that favors tuberculosis. But again, these findings are less than 20%. So that was about the radiology. Here, a message, one message to the audience is that when you really see this kind of abnormal please ask for referral. So we discussed about the clinical features, discussed about the radiology. The next thing is endoscopy, which is
again a very important test. Colonoscopy, I want to stress upon three very important things. That when you're doing a colonoscopy, please describe the lesion in detail. That can sometimes help you to say the exterior approach, describe the lesion in detail. Second is when you do the biopsy, biopsy should be taken from the lesion, but also take biopsy from the remaining organ because of the Crohn's disease. Many of these normal colonoscopy may have underlying lesion or something. So therefore, selective biopsy should be done from the remaining part of the organ. So the third thing is the remember differential diagnosis is key. He is an infectious disease. So therefore, we should be doing a microbiology. That's one area which is sometimes underutilized. We have to say specifically for microbiological tests, which is clear on the nucleic acid, application tests like Isgcon and culture. So please do not forget to send samples from microbiological tests. Describe the lesion, biopsy from lesion, send tests from microbiological tests. So colonoscopy, we should talk about the function of lesion, for example, this picture is a longitudinal ulcer displaying sclerosis. Here is the transverse ulcer, continuous ulcer, this creates tuberculosis. So here we have this graphical presentation of features of our nodes. All are we have longitudinal ulcer, after ulcer, skin lesion, left colon lesion. These are all Crohn's disease. If you have a transverse ulcer, if you have ulcer, you have but again, remember, it's not like you also there is some number. So it's not absolute difference. It's basically a relative difference, which is more common, which is less common. So that was about the colonoscopy. And let's talk about histopathology. Histopathology, obviously, both fruits and veggies are common application. Randomized studies are common. So histopathology is one area where significant contribution has been made by our center research. This is a paper published way back in 1999 done by Dr. and they showed that if you look at the granula influence directly, the feature of granula can help you distinguish those from tuberculosis. So if you want histology to see the cases of tuberculosis and if you see acid fast acid, then there is no confusion. Tuberculosis. But remember, acid fast acid cases of tuberculosis occurs at around 15%, not more than that. So therefore, the remaining cases will rely on other features. Granuloma is actually about 30 to 50% of Crohn's and about 40 to 70% of TB. So if you look at the granuloma, the pathologist looks at the granuloma directly. If there is a document diffuse granuloma, if there is a large cell granuloma, multiple like more than 5 or specific, subdivision location, this means tuberculosis. If we have small cell granuloma, that means Crohn's. Another feature which is very common in Crohn's disease is 60% cases are totally non-sterilized. But somehow this finding is not that much used. But I have for example, when we look at totally non-sterilized, then we can see that it's totally Crohn's. This picture shows very strong granules are fused together, multiple they are fused as malignant granuloma. Then we have a large cell granuloma, these two are tuberculosis. And then a small granuloma which is Crohn's. Finally, colonoscopy, biopsy, and anatomy is effects of multiple microbiological tests. There are multiple studies supporting this. Those are the studies quite a few from India as well. So this is the EMA histology. But when they are added microbiological tests in addition to histology, and if you look at the combined data, specifically goes about 70 up to 90%. So if you add histology and microbiological tests to a specific, you will need this much less. This is my third message of today's presentation. When you're doing a colonoscopy, the region looks like tuberculosis or Crohn's disease. You describe the region accurately and accurately because as I told you, the pattern of region can be protein, it's more like or normal Crohn's disease. The second is, apart from histopathology, we use it as specific for microbiological tests. So this is a summary again I went on details because I just discussed it in the time. Once you got the whole assessment from the future radiology, everything together, and then you make a decision whether it favors towards tuberculosis. A lot of people have actually probably the scoring system, including 1 from reads. Now, these scoring systems can be helpful, but actually in our clinical practice, we just look at the features and then we make our own clinical judgment, more likely to be, more likely to be. The final part of the presentation. So we have done everything. We have done clinical features, radiology, endoscopy, histopathology, microbiology. Still, we know a lot of patients. So there will be about 10 to 15% of cases who may like this. So in that patient, you are not having any choice but to give everything. But when you are giving everything entity, remember that after giving everything, these patients have to be closely followed up. Because 30 to 40% of patients who have closed, they also have symptom improvement. Diarrhea get better, pain get better, appetite get better. But they don't have any objective because the answers will not be. And to say stadium close, you have to document that there is an objective reason of patient. So you cannot go only by symptomatic improvement. So those patients who are on empirical entity, they have to be followed up. So in those patients, you need for 6 months. Very important you go for around 3 months. If the patient is not showing any sign of improvement, you repeat the markers like CRP or if the markers are still elevated, you do a colonoscopy 3 months. Then the patient probably is closed. Because the same aims to show that in TB patients, even at 3 months, more than 90% the lesion starts healing. This is my final message from my today's presentation. When you are giving empirical antidote therapy, please monitor the patient closely for response and look for objective assessments. I have not spoken about small bowel endoscopy. We know that TB can sometimes be influenced by small bowel endoscopy. So what I do for colonoscopy also works good for small bowel endoscopy, developing and doing enteroscopy. When you do bowel endoscopy, asparagus endoscopy, take samples for histopathology, lesions, send sample for microbiology. You assess the healing. For small bowel, maybe reading an endoscopy may be difficult, and you can do an endoscopy to see the lesion that's healing when you do endoscopy. So for colonoscopy lesions, we do rate colonoscopy. For small bowel lesions, we do rate endoscopy to assess the lesion. So as I said, about 10 to 20% patients we are still able to use our these are the types we talk about molecular tools, we talk about artificial intelligence. These are also being studied in clinical tools, for example, there are people from China that talks about machine learning tools for clinical tools. They take out proteomics, they specify organisms, selecting markers, peripheral blood cells, which we can use. Hopefully, these will come into the future as a patient will get better. So with that, I come to the end of our presentation. Thank you very much.
कैमरा में डालिए माइक कैमरा माइक ठीक है बोल दे जरूरत है बोल देंगे तब आ जाना माइक हेलो बोल दे रहे
क्यों देता रहा है ये तो ये ऑडियो
हाँ भेज देना
मैं इसको काट माइक इसका काट इसका लिंक शेयर कर दीजिए
हाँ एक मिनट
माइक इसका काट इसका है इसका माइक पकड़ रहा है फिर काहे पकड़ रहा है इसका हम काट दिए
हाँ
इसको मेरा आवाज इसमें पकड़ रहा है
हाँ
but does not distinguish the living from active. But data is better in classifying more specific policy. But when you have more specific, there is always a trade-off of sensitivity. So you pick up maybe some certain maybe about 15% active and about 50% latent in the documents. Second question about testing accuracy may be on 15 on variable result like a gamma like agent right now. This is this. This finding as well. So we for us every patient is unique and good thing is that we get results so quickly. Obviously, the newer generation of this area which is coming now, that we are finding it more positive steps are coming. What we have to do this year, almost every patient where a couple of years ago, anti-sensitivity or anti-inflammatory, subsequently we have new culture ready, we are doing a RANCHI culture ready now. So I think this is what hopefully we have done in all. We are doing every patient.
सब माइक ऑन है उसी का आवाज यहाँ आ रहा है अरे कम माइक अपना काट दो यहाँ भी काट वही पकड़
2000 and in 2010, the Panther trial, which is the landmark trial, it showed that if the intervention is done in a step-up fashion and the minimally invasive approach is adopted, it leads to better outcome. So the crux is that instead of doing an urgent open necrosectomy, the management of infected pancreatic necrosis has shifted to a delayed intervention, and that too in a step-up fashion. So what is the step-up fashion or step-up approach? So once the infected pancreatic necrosis is diagnosed or suspected, then you start with antibiotics. If patient is not responding in 24 to 48 to 72 hours, then you have to intervene with initially with percutaneous or endoscopic drainage. If patient resolves, well and good. If not, then you have to do a repeat imaging to see if there is another pocket of collection or pus which is flaring up the infection. Then you repeat the percutaneous or endoscopic drainage. If the patient is not responding, then you have to take the patient up for necrosectomy, and that too by minimally invasive approach, which is by laparoscopic or endoscopic necrosectomy. And there are few indications in around 50 to 20% of patients in whom open necrosectomy is required. So this is a step-up fashion in which the invasiveness of the intervention is stepped up, is done in a step-up fashion. So coming to the evidence, there are a lot of evidence now which has shown that the step-up approach is better in terms of mortality and morbidity. This is a large study of around 2,000 patients, which was published in 2017, that showed that in patients who were intermediate, high, or very high risk based on Apache 2 score and organ failure score, they did better in terms of mortality when the step-up approach was adopted. So this is the Panther trial, which is the landmark trial, and its long-term follow-up data, which was published in 2019, that also showed that the primary outcomes, that is mortality, as well as major morbidities, were less when the step-up approach was adopted. This is again one study which has shown that the 90-day mortality and 1-year morbidity and mortality were much less in the step-up fashion as compared to open necrosectomy. So coming to the surgical approaches for infected pancreatic necrosis, it can be broadly classified into two types, either open necrosectomy, that is the conventional approach, or the minimally invasive approach. The minimally invasive approach in turn can be divided into or broadly classified into surgical and endoscopic. Endoscopic I am not going to deal, it is the topic for next lecture. And the surgical part can be done in a retroperitoneal debridement or through the peritoneal route, that is the laparoscopic technique. So this picture shows how things are done. So this is the pancreas in which we can see the necrosum, black thing. So that can be approached either through the retroperitoneum, that is the video-assisted retroperitoneal debridement, or it can be done laparoscopically. It again is divided into 2-3 approaches, that is through the gastric wall, or through the lesser sac, or through the inframesocolic approach. So the most commonly done is the video-assisted retroperitoneal drainage or debridement. So I'll discuss about it. So the advantages are that it is associated with less surgical stress because general anesthesia sometimes may not be given. It can be done even under local anesthesia. And it avoids contamination of the peritoneal space. Ward is always the part of step-up approach. That is, first a percutaneous drainage is done, and via that route only, video-assisted necrosectomy is done. The idea behind placing the PCD first is that it drains the infected fluid which is there under pressure, and this results in decreased sepsis, improves general condition of the patient, and it also allows encapsulation or reabsorption of the necrotic collection. It is seen that in around 35 to 40% of cases, they do not even require necrosectomy. The PCD only is sufficient. So as we can see in this picture, that first the PCD is done through the left flank, and later on if the patient is not improving, then through that tract itself, necrosectomy is done. So a brief technical description, that it is done usually under general anesthesia. 3 to 4 centimeter long incision is given around the PCD, The necrotic collection is entered, the pus is drained first, then with the help of a 0-degree laparoscope, nephroscope, or even endoscope, whatever is at your disposal, we enter into the cavity, and with the help of sponge holder, we dislodge the necrosum and we do the necrosectomy. So, and after the necrosectomy is completed, we place 2 drains for the irrigation, and then the fascia is closed. So this is a small video. It's not playing. ये कैसे होगा? एंड शो करके एक सेकंड. Sorry for the interruption. So this is the small video that I would play. Yes, as you can see in the CT scan that there is a necrotic collection in which multiple PCDs are placed already. So the pus is draining, but the patient's condition was not improving. So through one of the PCD tract, a small incision of 3 to 4 centimeter was given. And then that tract was developed. The pus was sampled for culture and sensitivity. And in this case, a 0-degree laparoscope is inserted into the cavity. We can see the necrosum. Pus has already been drained, so whatever left is the solid necrotic material. With the help of sponge holder, we hold the necrosum and we try to dislodge it from the cavity. If that intervention is done in a delayed fashion, this entire thing becomes organized and can be taken out in a single piece. So you can see that the entire necrosis is being removed under vision. So this is how it is approached and removed through the retroperitoneal route. So it leads to very good vision, and after the necrosis is removed, we do irrigation of the cavity to remove the remnant pus and necrotic tissue. And after that, we leave 2 percutaneous drains there for irrigation in the post-operative period. Okay. I'll have to stop the PPT and play the video again and again, so that's the problem. So as we can see that after the post-op ward is done, 2 drains have been placed for continuous lavage, and the empirical antibiotics are started initially, and later on culture-specific antibiotics are given. And then the stepwise retraction of PCD is done once the output is reduced and the cavity is closed. So coming to the, I have discussed the ward, that is retroperitoneal approach, and then coming to the laparoscopic approach, it is again of, we can approach the necrotic cavity through transgastric approach or through inframucolic approach or through lesser sac. So to approach the lesser sac, just to show you how we approach it laparoscopically through the lesser omentum. We open the omentum and then we enter into the lesser sac. Again, I'll have to end the show. So you can see that we are opening the omentum to enter into the lesser sac. We are using harmonic ACE device, which cuts and coagulates at the same time. Here we find normally pancreas, but in this case there is an encapsulated collection around the pancreas. We aspirate it first to be sure that we are at the right place. and then with the help of suction cannula, we enter into the cavity. The aim is to aspirate the pus and so that the remnant solid necrosis is dealt later on. So we enlarge the opening again with the help of harmonic ACE device, which is based on ultrasonic shear principle. It cuts and coagulates. That is why the bleeding is less, because this capsule sometimes can be vascular and lead to bleeding. So you can see the pus, which is very thick. So to suck it out, sometimes we irrigate it time and again so that it gets diluted and it becomes easy to suck it out. A plastic bag. Now, when the entire pus is drained out, the solid necrotic material is left in the cavity. Again, it is organized, and if taken out carefully, it can be taken out in a single piece. You can see that gently we are trying to dislodge it from the cavity. Plastic bag has been placed in the peritoneal cavity so that the entire necrosum can be kept there, because it has the tendency to get lost into the bowel interloop. Then again, it may lead to abscess formation at a new place. So here you can see how we are taking it out, placing it in the bag, and like in the same manner in VARD, after the necrosectomy, we irrigate the cavity and suck out all the remnant pus and necrotic tissue. And at the end of the procedure, we place a drain so that we can irrigate the cavity in the post-operative period. So this is how it is done. And another approach of laparoscopic technique is to approach the necrosum through the stomach wall. So this is done when the necrosis is in the relation to the posterior wall of the stomach. So first we open the anterior wall of the stomach, and then we approach the necrosum. Very small video to show how we do it. Here we are opening the anterior wall of the stomach. You can see the Ryle's tube is in the gastric cavity, and with the help of stapler, or we can use harmonic ACE also, we open the cavity. I have already skipped that part where we are sucking out the purulent material. Now this is the necrosis. We are taking it out in the piecemeal fashion. And it is again kept in the plastic bag and removed. And once the procedure is completed, we repair the anterior wall of the stomach with the interrupted sutures. So these are the various approaches for necrosectomy in a minimally invasive fashion. So what is the role of open necrosectomy in the current era? So open necrosectomy is now less commonly used, but still very useful where there is treatment failure or complication during step-up management. Sometimes while placing the percutaneous drain or doing a necrosectomy, there is damage to the colon, or patient may bleed also. So in those situations, open necrosectomy is very useful. Disease process per se leading to bowel ischemia or perforation, in those scenarios, open necrosectomy has a place. Places where there is lack of expertise or equipment for performing minimally invasive necrosectomy is again an indication for open necrosectomy. And anatomically widespread necrosis where there are multiple pockets widespread in the abdominal cavity, or there is disconnected left pancreatic duct syndrome, which is aggravating the disease. But this open necrosectomy is associated with significant morbidity and very high mortality rates because patient already is sick on vasopressor support. So performing a major surgery, bilateral subcostal incision is going to add to the morbidity. And again, it can be associated with early complications like bleeding or pancreatic fistula formation, and late complications like incisional hernia formation, or as PANTER trial follow-up data has shown that the pancreatic function is also inferior as compared to step-up approach. But still it can be life-saving in limited resource setup, and it facilitates most complete debridement, and in 75% of cases, single-time necrosectomy is sufficient. So these are few advantages of open approach, but it is less commonly performed. So my last slide, the take-home message is that the infected pancreatic necrosis in itself is not an absolute indication for necrosectomy. Intervention should be delayed by 3 to 4 weeks so that it becomes walled off. And step-up approach improves outcome as compared to open necrosectomy. Minimally invasive approach is preferred, and open necrosectomy has its place only in some special circumstances. Thank you.
Very nice presentation by Dr. Shakit Kumar. But questionnaire will be taken after the second lecture by Dr. Soumya Jagannath Mahapatra, because both the topics are related together. Dr. Soumya Jagannath Mahapatra is Assistant Professor of Gastroenterology, AIIMS, New Delhi, MBBS, MAMC, MD, MAMC, Fellowship in Gastroenterology and Advanced Endoscopy in AIIMS, New Delhi. This topic is endoscopic management of peripancreatic fluid collection in acute pancreatitis. So start, sir.
Good morning, ladies and gentlemen. I would like to thank Isgcon group for inviting me for this topic. So my topic of discussion is endoscopic management of walled-up necrosis in patients with acute pancreatitis. So we will discuss under these outlines. So briefly, I will touch upon the revised Atlanta classification, which my friend Dr. Saket has very well described. If the pancreatitis, it can be acute interstitial pancreatitis when there is inflammation, edema, or it can be acute necrotizing pancreatitis when there is pancreatic necrosis. Over time, usually when the wall is not formed, acute interstitial pancreatitis develop into acute peripancreatic fluid collection, while acute necrotic collection develop from necrotizing pancreatitis. So usually after 3 to 4 weeks, when the wall is mature, the acute peripancreatic fluid collection develop into pseudocyst, and acute necrotic collection develop into walled-up necrosis, which contains necrotic debris. So what are the patients which are suitable for endoscopic drainage? So if you can see on the upper panel, so there is a collection which is predominantly subhepatic. It is anterior to the stomach wall. However, the collection in the inferior panel, it is just posterior to the stomach wall, and it is in lesser sac. So the upper panel, if you do a endoscopic cystogastrostomy, the collection, some part of the collection is intraperitoneal, and there is chances of peritoneal leak, which may happen. So it is not a suitable candidate for endoscopic cystogastrostomy as compared to the collection in the lower panel. There should be close opposition between the wall of the collection and the stomach. You need to assess the amount of necrotic debris prior to doing a endoscopic drainage, because that will depend upon your choice of stent. You should assess the wall maturity and thickness prior to do endoscopic drainage. So if you can see the figure A, there is a collection which is exactly in the lesser sac, posterior to the stomach. There is a close apposition. Wall is matured, is good for endoscopic cystogastrostomy, as compared to the collection which is predominant in the subhepatic. In the right side of the abdomen, there is some distance between the collection and the stomach wall, and there is chances of leak because it is subhepatic collection, is not suitable, and the collection C is very far from the GI tract, so very far from the stomach and duodenum. It is not suitable for endoscopic drainage. So what are the stent we can choose for drainage? So between the metal and plastic stents, metal stent having wider bore lumen, there is chances of better drainage, and in fact you can go inside those collection later on through the stent and do the debridement the next day or the same day also. However, it is associated with significant adverse event which we'll discuss. It has higher cost as compared to plastic stents, which is narrow lumen stents, which have chances to get obstructed by the necrotic debris. And these stents are relatively cheaper and safer. So there is one randomized control trial which compared lumen opposing metal stent over plastic stents for drainage of world of necrosis. So in this, there is length of hospital stay was significantly lower in lumen opposing metal stent as compared to plastic stents, because with plastic stents getting obstructed by the necrotic debris, chances of re-intervention were higher. However, there are significant adverse events if the lumen opposing metal stents were kept for 3 weeks or more, which we'll discuss. So they made a protocol change after including 8 patients, so in which they did a CT at 3 weeks and removed the metal stent if the collection has resolved. And with that per protocol change, the adverse event rates were similar. So there are multiple systemic review and meta-analysis which have shown that lumen opposing metal stents and plastic stents are associated similar rate of adverse events. However, lumen opposing metal stent having a wider bore requires lesser intervention and there is better drainage with lumen opposing metal stents. However, this systemic review and meta-analysis are limited by significant heterogeneity. Most of the studies are retrospective and there is one randomized control trial only. So in general, which type of stent to choose? So if the patient is having a pseudocyst, which is a predominantly liquid component, we choose in a plastic stents, and if the necrotic debris is less than 30%, we choose plastic stents given the safety factor and the cost factor. And if it is world of necrosis, necrotic debris is more than 30%, or the patient is having infected world of necrosis, running fever, having organ failure, we need a better drainage and we may need earlier debridement, we choose a metal stent. So how do you assess necrotic debris? Can be assessed by ultrasound, by ellipsoid formula, or can be assessed by MRI. So this is a video showing placement of plastic stent. I think वापस कैसे जाएंगे? अच्छा अच्छा, ठीक है, ठीक। नहीं, वो वाला मेरा वाला कहाँ पे है? नहीं, ये वाला कहाँ पे है? हम स्लाइड्स वापस कैसे जाएंगे? वो जो ये वाला है, ये इधर से So this is a video which is showing a lot of necrotic debris, and this is a hot exhaust stent which we have put for drainage. So under US guidance we could puncture the site and put a hot exhaust stent. So the other part of the video is not running, so I will, so there is a video for endoscopic necrostectomy, so I could not have that video. So we can easily go through the endoscope into the cavity and we can easily debride the necrotic debris. This is what the debrided cavity looks like. So what are the complications during endoscopic cystogastrostomy or cystoduodenostomy? There is immediate or early complications such as bleeding during puncture. So puncture site bleeding, there can be a perforation if the wall is thin or there is not closed apposition, or there can be maldeployment of the stent which can migrate into the cavity or that can migrate proximally, or there can be delayed complications such as delayed bleeding, buried stent obstruction, or migration. So as you can see, this is in the left panel of the video of the figure. So after endoscopic cystogastrostomy and placement of the lumen opposing metal stent, patient presented with bleeding, delayed bleeding after 4 weeks. As you can see, once the cavity collapses, the inner flange of the stent that migrates towards the opposite wall and it's impinging on the left gastric artery branch, and the patient was bleeding due to that. If you want to take out that stent, the patient will bleed massively. So we did an radiological angioembolization of the left gastric artery and subsequently took out the stent. I think this video will also won't play. I will go to, so So for endoscopic drainage, which modality should we choose, endoscopic or laparoscopic? There was a study from All India Institute of Medical Sciences which we published in 2020. So we included 60 patients randomized to endoscopic and laparoscopic arm. We included a patient with less than 30% of necrotic debris and used only plastic stents. There was similar success rate, but there was higher infection rate in the endoscopic group because of placement of the plastic stent and repeated obstruction of that stent, and resulting in higher infection. Subsequently, we did another study in which we placed metal stent if the necrotic debris is more than 30%, so that we can go through the stent and debride the necrotic debris if feasible. So overall success rate was similar, and overall hospital stay was significantly lower in the endoscopic arm. So we would suggest endoscopic transmural drainage with either lumen approaching metal stent or plastic stents tailored to the amount of necrotic debris is as effective as laparoscopic damage is patient with symptomatic peripancreatic fluid collection, and hospital stay was lower with endoscopic drainage. भैया ये वीडियो नहीं चल रहा है। एक मिनट, पुराना वाला फ्लाइट, पुराना वाला वो कर दो, एस्केप करो, वो वाला एस्केप नहीं हो रहा। अच्छा इससे होगा, ठीक है ठीक 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 है ठीक है, मैं इससे कोई नहीं। So this is a patient who underwent laparoscopic cystogastrostomy. After a month, he presented with abdominal pain, fever, and signs of sepsis. So, as you can see, this is the residual collection. This is the laparoscopic cystogastrostomy stapler site, and it is being obstructed by ingrowth of the mucosa, and so there is remnant collection. So our surgeon wanted her to do whether we can approach that cavity through endoscopy route. So we went through the endoscope, we identified the stapler site. So there was a minimal small opening, and we entered that through a cannula. And once we irrigated the tract, the necrotic debris came out from the tract, and there was a lot of pus which gushed out from the cavity. So that confirmed that we are inside the cavity. And subsequently, we dilated the tract with a CRE balloon and placed a plastic stent. And after a day or two, went inside and do the debridement of the cavity. Follow-up EUS revealed so after the procedure, we did a EUS whether we are in the right tract or not. So it revealed that there was no residual collection. So surgeons and endoscopists work in harmony. So surgery is needed if there is complication during endoscopic cystogastomy, such as bleed or perforation, wall of necrosis not in the lesser sac, it is predominant in the subhepatic phase, or there is extensive necrotic debris, predominantly necrotic debris more than 70%. And endoscopist is needed if there is no visible bulge in the stomach, so you can puncture through US guided. If there is extensive collateral around the wall of necrosis, so you can do a puncture under US guidance, avoiding the vessels. And as we have shown the post-lap cystogastomy, if there is residual necrotic debris and the patient is having fever, then we can do. So now only we have discussed the collection which is predominant in the lesser sac or which is accessible from the stomach and duodenum. But in our practice, we usually don't see this. We predominantly see a different group of patients in whom the collection is far away from the stomach, and that is not accessible for endoscopic transmural drainage. So as you can see in the picture, the collection is predominantly in the left flank and the pelvis, and there is small collection in the lesser sac. So these collections are not accessible for transmural endoscopic drainage. This collection is also, and similarly this collection. So how do we manage this patient? These patients are super sick. When they're present, they are having infected necrosis, they are having organ failure, sepsis, they get directly admitted to the ICU. So this was the seminal paper published by Professor Garg in 2015 in GI endoscopy. As you can see, this is a patient with infected pancreatic necrosis who is on ventilator and having chest infiltrates, PF ratio less than 100. And we put a catheter, we gradually upgraded the catheter, and we entered the catheter through endoscope and do a percutaneous endoscopic lavage or sinus tract endoscopy and take out the pus. And gradually the patient improved over time. So initially we took 15 patients with infected pancreatic necrosis and ongoing organ failure. We did mean 5 sessions of percutaneous endoscopic necrosectomy. One patient required open surgery. So it was a safe and effective option. Subsequently published another paper with 53 patients who underwent percutaneous endoscopic necrosectomy, and 80% of patients could be successfully treated, 8 needed surgery and 11 died. The independent predictors for mortality was significant necrosis and early organ failure. So subsequently, since the patient who are having this collection which is far away from the stomach and extensive pelvic paracolic gutter collection with infected debris, these are the patients who are very sick, though these patients are not suitable for open surgical debridement or general anesthesia. Once you put a percutaneous catheter drainage, sometimes they improve, sometimes don't. So we need to develop a method so that we can accelerate their recovery. So we developed a protocol, accelerated combined catheter plus percutaneous endoscopic treatment for enhanced recovery. I will show the video. So this is a patient with extensive necrotic debris, which is predominantly in the flank and left side of the abdomen, extended in the pelvis. So these are the catheters. So we could place 2 catheters in the paracolic and the pelvic collections. So these are the 2 catheters. This is the pelvic and this is the paracolic gutter. Subsequently, we could enter into the cavity. Gradually, we upgraded the catheter of the pelvis. Initially, we usually put a 20 French thal set. Then gradually, we enter to the cavity through the using an ultra-thin endoscope and wash the cavity. Subsequently, we upgrade the tract every time to 2 to 4 French, and subsequently upgrade it to 32 French tube, and so that we can enter with upper GI endoscope. And once you enter into through upper GI endoscope, we gradually took out the necrotic debris using a snare or a Roth net. Subsequently, the cavity is irrigated, and subsequently, after repeated session of endoscopic session of endoscopic lavage, the cavity becomes clean. So subsequently, we could enter the lesser sac cavity. Just forward. So these are the necrotic debris which you could retrieve from the pelvic cavity. Subsequently, for the lesser sac cavity, we could not dilate it, so we put a fully covered self-expanding metal stent, esophageal stent, through the lesser sac cavity through the intercostal approach, and this is the metal stent. And subsequently, after a day or 2, we went inside to the cavity through the metal stent, and with the Roth net and snare, we could debride those cavity. And this is the endoscopic view after complete debridement. Both the cavity were communicating and both the cavity were clean. And so these are the necrotic debris. So this is the follow-up MRI which showed complete resolution of the collection. So, to conclude, so nature of world of necrosis should be characterized prior to drainage, the amount of necrotic debris, its location, and whether it is infected or not. Laparoscopic and endoscopic drainage have similar efficacy and shorter hospital stay with endoscopic approach. Surgeons and endoscopists should work in harmony, and the collection which were inaccessible for transatrial drainage. So apart from VAD, percutaneous endoscopic necrosectomy is a very good option. So these are my comments. I would like to thank Professor Pramod Garg, who has been my mentor and has been teaching these procedures day in, day out in All India Institute of Medical Sciences. Thank you.
Thank you very much, Dr. Soumya and Dr. Saket. These two people have given very good pictures of how to manage these cases. The topic is very hot. You know, the necrotizing pancreatitis is a common problem for every surgeon and every gastroenterologist. I think it is open for discussion. Please do ask questions. Any questions?
All right.
Maybe have Dr. Saket on stage, please. One query is regarding sort of VADs. What are the techniques we can use for less invasive drainage of the pancreatic necrotic collection? Sort of VADs. We don't have video-assisted facility available.
Actually, video-assisted facility is not very, it's available everywhere, because you can use either endoscope, normal endoscope, or you can use nephroscope, or even 0-degree laparoscope. Whatever you can, any video device you can put through that tract and see the cavity and take the out. If you don't have that facility and patient's condition is deteriorating, then you have to resort to open necrosectomy. So, or as I have said, that you can deploy percutaneous drain, if not one, then multiple. So that has been shown to be effective in around 35 to 40% of cases, and those patients do not require necrosectomy. So PCD in itself can be curative.
So if I would like to add something, if the patient is not, well, if you don't have the facility for VAD, or if you have an endoscopist over there, you can actually do percutaneous endoscopic necrosectomy or percutaneous endoscopic lavage. The advantage of percutaneous endoscopic lavage and necrosectomy over VAD is you don't need a general anesthesia in general for percutaneous endoscopic lavage or percutaneous endoscopic necrosectomy. You can do some minimal sedation like some propofol or midazolam, smaller doses. The patient tolerates well this procedure because and you can repeat it multiple times. You can go into the cavity, wash it, come back, and if the patient improves or if the patient deteriorates, you can go after a day or two and do the procedure. If the patient does not tolerate, you can abandon the procedure after half an hour. So that's a procedure which may come over time, which you can do.
One question, Dr. Saket. How do you manage if there is a hemorrhage while you are taking out the necrotic tissue? If there is a hemorrhage, how you are going to manage that one?
Yeah, it depends upon the severity of the hemorrhage. If we are doing VAD and there is hemorrhage, we can pack the cavity, and if there is arterial bleed, we can go for radiological embolization of the vessel if it is an arterial bleed. But these are the methods like packing the cavity or using a radioembolization, etc. If nothing works, then open necrosectomy, open surgery has to be done to save the patient's life.
Any questions? Thank you very much indeed.
Thank you, sir.
It was an excellent presentation and we appreciate very much. Thank you very much.
Thank you so much, sir. We'd like to call upon the chairpersons to felicitate Dr. Saket Kumar, sir, and Dr. Soumya Jagannath, sir. Now we will felicitate the chairpersons. Thank you so much, sir. Now moving on to the next session, we have our speaker, Dr. Supriyo Ghata, Kolkata, and for which the chairpersons are Padma Shri Dr. Vijay Prakash Sir, Professor and ex-HOD of Gastroenterology Department, PMCH, Patna, and Director of Big Apollo Spectra, Patna. And we have Dr. R.R. Singh, Consultant Surgeon, Ranchi. Can we have the chairpersons?
It's my proud privilege to invite Dr. Supriyo Ghatak, who is Senior Consultant in the Department of Liver Transplant and Hepatobiliary Pancreatic Surgery at Apollo Multi-Speciality Hospital. He has done his MS from PGI Chandigarh in 2003 and MCH from AIMS Delhi, and has been a faculty of IPGMER Kolkata and CMRI Hospital Kolkata. Has many publications in national and international journal, and has written a topic on overview of liver transplant, and he is going to enlighten us on overview of liver transplant.
Thank you, Chairperson, sirs, and I'm very honored to be here to present before you in this August gathering, and I would like to thank the organizing committee, Dr. Ghosh, for inviting me as a speaker here. So my topic that has been given to me is an overview of liver transplantation. So I'm coming from Kolkata Apollo, and greetings from Kolkata Apollo, our Institute of Gastrosciences and Liver Transplant. In that institute, we work in a team. In our department, we are 3 senior surgeons. Other than me, there is Dr. Shumit Gulati and Dr. Ramdeep Ray, and also a very compact team of anesthetists and intensivists and hepatologists, all people who are an integral part of the transplant program. It is well known that without a proper team, you cannot do a complex procedure like liver transplant. So we are indebted to all the members of the team. We are very familiar with all these features of end-stage liver disease, and I'm not going into details because you are all aware of these things, that this deep jaundice or refractory ascites or GI bleeding, hematemesis mellitus, and along with the ominous development of sometimes in some cases of cirrhosis, the development of HCC. These are all indications of transplant, liver transplant. Now other than that, there are many rare or other diseases where transplant may be required. And when transplant is, when we talk about the indication of transplant, there are only 2 things. One is which disease that needs a transplant, and second is when to transplant. There are many diseases where you can wait for some time, and there should be a perfect time when it should be intervened. So we need to know at what point of time we need to operate these patients. Commonly in India, we have, these are the causes we see in our center is commonly NASH and alcohol and hepatitis. These are the common etiologies. Now, cirrhosis, whenever they are presenting with an episode of decompensation, there you should start talking about liver transplant. You should broach the subject to the family, to the patient, that the patient may require a liver transplant. Maybe you can, if you start thinking about that, if you start searching in the internet, searching for donors in your family and all, then ultimately it will be done at the correct time when it will be necessary. So the decompensation, we all know that the ascites, jaundice, and this thing, encephalopathy, or these are the things that you should be very wary of. Now, for determining when to transplant in cirrhotic patients, we don't need many investigations. This simple slide of few investigations can tell you when the patients will require a transplant. We have to look for bilirubin, we have to look for albumin, we have to look for INR. Platelet will give an idea about portal hypertension. And we need an imaging to rule out any HCC. And upper GI endoscopy to again look for portal hypertension. Now, we know that we have the child score, and we don't need to actually remember the score anymore because we have online. Everyone has internet access in their mobile, and you can easily calculate the score with an online child score. And as you can see, it gives the result in 3 categories, A, B, C, we all know. And when there is child's B status with decompensation or child's C status, they are candidate for transplant. Actually, we don't need anything else other than this, especially in India, as we don't have a proper organ allocation system or such waiting list that needs to be maintained on the basis of severity of the disease. There are very few numbers people waiting in the waiting list, and in case of living related donation, there is no need for MELD. Because MELD is basically when you are listing the patient and patient is going to get an cadaveric organ. There the importance of MELD lies. But by childs only you can tell which patient needs transplant, and if in India at least, this is enough for listing the patient for transplant. And usually nowadays it is based on only waiting time, not on severity of the disease as such, as the numbers are few. Now, MELD score, if you are using it, we all know that a MELD of 15 or more is, you can transplant, you can enlist the patient for transplant. And there are some MELD exception scores also. And MELD is, again, you don't need to remember, it is there. And now it incorporates sodium, and it incorporates the dialysis, the need for dialysis and all. So this is the MELD score which we can calculate online only. And as I told you, B, child's B with decompensation, or child C or MELD score of 15 and above is an indication for transplant in cirrhosis. In other diseases, it is different. For example, in acute liver failure, what we follow in our center is King's College criteria. And there are 2 different subsets. One is paracetamol poisoning, and other the non-paracetamol. And in India, we don't see much of paracetamol poisoning. So we have to look only on the right side of the table when you determine the criteria for transplant in ALF. And as INR is an integral part of this score, so we only, I think, as a surgeon, we would like to emphasize that we should not use fresh frozen plasma or other therapies just to correct INR in these cases. Because if you do that, then you falsely normalize the value, and that patient, even if he or she is a candidate for transplant, will be denied a transplant based on the INR value. So we should not give any therapy to coagulopathy just on the lab report, unless the patient is having bleeding tendency, or you are going to do some invasive procedure like some monitoring or something. So these are the criteria when an ALF patient should be referred to a transplant center. This is very important, especially when you see an INR of more than 1.8. and patient is developing hepatic encephalopathy, patient should be transferred to a center where transplant is done. These are just two pictures how the liver looks like. The left one is the cirrhotic liver. This is one nodular hard liver, and this is one is the ALF, the necrotic liver in case of acute liver failure. Now, when we have patients like this with chronic liver disease or acute liver failure or other diseases which needs transplants, where do we go? We go with a begging bowl, and often we end up in getting the organ from a brain death patient. Now, when a death occurs, especially a brain death, although it could have saved, say, as many as 8 lives, if you donate the organ, but most of the times the organs are wasted. So this one life-changing event that could have happened if they had donated or their family had consented to organ donation, that could have saved many lives who are waiting for an organ. So I think we should pledge our organs to save a life, and in this hall, whoever are present, if as an ambassador of the society, as an important person of the society, as we come into contact with various people in the society, we should first ourselves pledge organ donation, and we should make aware of our family of our wishes that we want to donate organ if the situation arises, something happens like that, unfortunate thing. Liver regeneration. This is a wonder of nature, I may say, because the other organs are not like that. Now, we all know that we have one liver, but for surgeons, this is actually 8 pieces, the separate pieces which can be separately removed. And in living-related transplant, usually what we do is we take out one side of the liver, right side usually for an adult, and we implant it to the recipient. Now, liver looks opaque to us, but we want to see it not opaque. We want to see it like this. We want to see it transparent so that we know where exactly are the veins, arteries, the ducts, everything. So nowadays, radiology has made this possible. How? Previously, we used to see pictures like this, but nowadays radiologists are good enough and they give us pictures like this where we can actually do the surgery, do the transplant, the donor part beforehand in the radiology console, where you'll get all the details. Like in this picture, you get the details of tributaries of the hepatic veins, middle hepatic veins, and you can decide which side to go when we do the transection. So these are all So these are the venous branches that are divided. So I'll not go into details of this. I'll just show a brief glimpse how it is done, that's all. Now how we take out the graft. We start with the artery. This is the artery that is being tied. The blue slings that you are seeing, I don't have, this thing is working. This is not working pointer, but the 3 blue slings that you see, the top one is the segment 8, and then the segment 5, and next is the portal vein that has been slinged with blue slings. That is the arterial end. Next we are clamping the portal vein at the junction, bifurcation, and we don't want any narrowing at the junction. Oh, that is not working. I think battery is something wrong. So that is the portal vein. And then we go up and divide the segment 5, 8. Where? It's not there. Okay, I think because of the screen itself. Okay, these are so this is the left side, what we have taken out, the right graft, and the left side, the left picture, what we see is what is left behind in the donor. So next is the top where the forceps is holding and the clamp is there, not the white one. That is the anastomosis between the right hepatic vein to IVC. And the white one which is there, that is actually reconstructed neo-MHV that will be done to the IVC again. Now how do you check the portal flow? As you see, this is a good portal flow will hit actually some point away from the opening. So that is the way how we check it. And this is the graft right portal vein to portal vein anastomosis. And this is the right hepatic artery to right hepatic artery anastomosis. And this is done with, always we do all the anastomosis with under magnification with loop, and this is with 8-0 sutures. So next is the biliary anastomosis, the completed transplant that we look here. Now as you see that liver transplantation is actually, if you look at it, it is more of a vascular surgery rather than a liver surgery. In living related we do a transection, but in cadaveric we just take out the diseased liver and put a new liver. So there are only anastomosis, vascular anastomosis, hepatic vein to IVC, portal vein to portal vein, like this. So it is more of, you can say, a subspecialty vascular surgery, subspecialty of HPB surgery or GI surgery. So what we do is we change livers, and that change lives. And as you see, it unlike kidney, which has a lifespan, the graft usually lasts for 10 to 15 years. In liver, there is no such limit. This is the patient, the first transplanted patients by Thomas Sturgill, the initial group. The picture, the C marked picture is the before surgery, and on the right side it is after surgery, and then the next, the lower one picture is after 46 years after liver transplantation. That was first time done in the world. So in our center, there was one documentary maker, a video maker, who thought of he went to a recipient and a donor of living related liver transplantation from before the surgery, and followed their journey from before surgery to hospital, and then recovery and post recovery life. And he made a documentary which has been selected in the this film festival also in the documentary section. I think it will be available in the YouTube also soon. And although we rely more on living related transplant because of the scarce availability of the organ, but in recent few months we have done 6 cadaveric liver transplant. That is a good news because we want the awareness to rise, we want cadaveric donation to rise, because that way it is the safest way of doing the transplant, because when you are dealing with a living donor, there is always a risk, whatever minuscule it is there, so it is better to have a cadaveric program active, and it should be, widely organs should be available and with a good network and waiting list thing. Thank you.
Thank you, Dr. Supriyo, for your nice presentation on overview of liver transplantation. Any question from the audience? Topic is open for discussion. Any question from audience?
My question is that when should we, refer the patient for liver transplant? When should we say that now liver transplant is needed?
So that is what I said, is that there are few diseases where you need liver transplant, and there are in the timeline of that diseases you have to find the perfect spot when you have to send the patient for liver transplantation. So first, all chronic liver diseases which end up with cirrhosis, that is one indication. Acute liver failure with very high INR more than 1.7 and development of encephalopathy or bilirubin of more than 17.5 should be referred to a transplant center. All cirrhotic patients with a feature of decompensation should have a transplant referral. And other indications are rare metabolic diseases and all. So these are individual patients, but most commonly we are dealing with either cirrhotic or acute liver failure. In these two case settings, I think this is the most important point to remember for referral to transplant center.
Yes.
Patient of alcoholic hepatitis or alcoholic liver disease, if is planned for LDLT. So is there any period of abstinence from alcohol that we follow in our country?
There is an informal time period of 6 months which need to be maintained in many centers. It is individual thing. There is no evidence-based data to say that 6 months is the correct time, because it has been seen that people who are not taking alcohol for 3 months also did similarly well. And even it has been seen that patients who are taking actively alcohol before the transplant also, the incidence of recurrence, re-drinking is not that much. It will go up to 20-30% in the post-transplant patients who have been transplanted for alcohols, but that developing into a situation where the patient requiring retransplant is very rare. So it is not a contraindication. It depends on individual institution and their policies.
Does it make a difference whether DDLT or LDLT is planned? Because in that case, it may be the family decision that we want to get transplantation, and abstinence from 4 or 6 months, it is variable at different places. For example, in Mumbai, we used to follow 4 months period. So does it make a difference there?
I said that it is an institutional policy and government decision, because organ is a national asset. So organ, if we are talking about cadaveric organ, there can be a law like that. But as we say, we are still in the infancy in the organ donation part.
Any more questions? So there are no more questions, and we close the session here.
Thank you.
Thank you so much, sir. Now we would request the chairperson to kindly felicitate sir. Now we would felicitate our chairperson, sir, Dr. R.R. Sinha, sir. Now moving on to the most awaited session for day. We'll call upon the chairpersons, Dr. B.K. Agarwal sir, Consultant Gastroenterologist Patna, Dr. Manohar Lal Prasad sir, Associate Professor RIMS, Dr. Vijay Shankar sir, Consultant Gastroenterologist Patna, Dr. Ramesh Chandra sir, Consultant Gastroenterologist Ranchi. Now I would request the chairpersons to kindly welcome the guest of honor for today, Padma Shri, Dr. D. Nageshwar Reddy. A big round of applause for sir. Sir is on the way. He's coming in 2 minutes. Just bear with us.
कनेक्ट कर लेते पहले कनेक्ट करने दीजिए ना पहले नेट नेट चल रहा है।
इतना ही रहेगा। Welcome, sir. I would request our chairpersons to kindly welcome our guest of honor, Padma Shri Dr. D. Nageshwar Reddy. Big round of applause, everyone.
हाँ सारा कॉपी कर लीजिए.
Good morning, Nagi. This बाटा नहीं पढ़े.
प्रेजेंटेशन का भी कुछ यही फ्यूचर
अभी लो बाद में कर.
एक प्रेजेंटेशन हम बाकी वीडियो है अपना कुछ किया अपना देख लें. हाँ हम बस
I will request press to do their job after his lecture is over. So press. Nageshwar Reddy, this is B.K. Agarwal. Good morning here. So I think about him, I would say you have already read his biodata and all that. I can say that if you do not know Nageshwar Reddy, you do not do endoscopy. Anywhere in the world, I would say. And so in another 2 words, I would say he is a golden flower with a fragrance. Nagi.
So, first of all, I'd like to thank the Indian Society of Gastroenterology, both Bihar and Jharkhand, for giving me this opportunity to be here. I've been here many times, and of course, this is a very warm welcome. So many friends, and after the COVID period, I think we're meeting after a long time. So it's a very nice occasion for all of us, and I'm also very impressed with the progress that Isgcon here is making because of, I think, so much interest everybody takes in this conference. So I've been asked to talk on future of endoscopy, what are the new innovations that are coming in this area. So of course, whenever you want to know about future, you must look into the crystal ball. So I put on my turban and looked into the crystal ball of endoscopy, and I'll try and predict some of the things that's happening or in fact are already happening. Some of you must have been in the endoscopy workshop yesterday and seen what's happening. So let me tell you how endoscopy is totally changing the therapeutics of gastrointestinal diseases. In fact, there's a revolution in both techniques and technology. And endoscopy is a technology-driven subject, and therefore, whenever new technologies come, they dramatically change what is happening. So there are new scopes, new accessories, and so on. In fact, if you look at the gastrointestinal endoscope that we use today, it was designed 50 years back by Japanese. The same style, the same technique, it's going on like this. But this, of course, is going to change, and they will definitely change in the future. And one of the changes that has occurred is because of this, what happened a few years back in US. This was in January 2015. There was a big news item in US, all the papers, that there was a deadly bacteria which was present in the scopes, which was infecting, cross-infecting the patients. And this was initially linked to some deaths in California, and later it was found that in many centers in US and also in Europe, some in India, that there was this very resistant, carbapenem-resistant bacteria which was present in the ERCP scope, producing endoscopic infection and deaths. So this raised a big alarm in FDA and among the public, and soon FDA came up with the concept that you must start thinking of disposable endoscopes. Sometimes I used to have some very rich patients coming and telling me a few years back, can you do my endoscopy with the disposable scope? We used to laugh at that time and tell, okay, you can buy a new endoscope and donate to the department. We can use it for the patients further. But this has become a reality now, disposable scopes. Already we're getting sterile single-use endoscopes. Now, I've used some of these scopes, and you can in fact see that these scopes, the picture quality is very good. This is a colonoscope made by Ambu company, and you can see the quality of picture is very good, almost like the regular scopes. The cost of this scope currently is about 300 euro. So for Indian context is still costly, but not for in their context, because the colonoscopy charges are 1,000 euros, so 300 they can pay. But for India, but what will happen is both Indian and Chinese companies are going to come up with scopes like this at a very low cost, and we are going to start practicing this type of medicine. In fact, what has already arrived and what is available is the single-use duodenoscopes. So for ERCP, in certain category of patients who have high risk for infection, who have possibility of a multi-drug resistant organism attacking them, for example, if patient has malignancy, we have started now using the single-use duodenoscope. It's called the XL scope. It's available in the market. Now we have it actually in our department. And these are two videos I wanted to show you about how this scope were used. You can see very clearly here that the scope is taken out of a packet. And then this was the first live demonstration we did last year. And this scope is attached, and you can see the picture quality is very good. It's almost as good as the regular duodenoscope. Of course, the thing about this scope is, and you can see that we removed very complex stone, in this case very large CBD stone. And the most important thing is after the scopy is over, we take the scope and throw it in the waste paper basket. So this is the thing about this scope, and this currently, of course, we are using it only in certain indication. It is quite expensive. It is costing about 2 lakhs and odd. But what is going to happen is that the costs are going to come down. It is believed that if the cost of the scope comes to about $200 in Western country, then all regular scopies are going to be done by disposable scopes. And I think that day will come very fast. My prediction is that in 5 years' time, even in our country, many of the endoscopies will be done by disposable scopes. And what we used to do, I think BK will remember, or Vijay will remember, that what we are doing as about 30 years back has totally changed now. Even to think of the concept of disposable scope is something which is no. So we are going, at present we are limited use, but in future it's going to become very commonly used. The other area where there is going to be dramatic increase is robotic endoscopy. Now this is a surgical Da Vinci system where surgeons for more than 20 years now, and now very, very commonly almost every big hospital has got this robotic Da Vinci system. But we don't have it in endoscopy because it's very difficult to make a flexible robotic system. Some time back we did this robotic system in Hyderabad. In fact, this was the first robotic assisted endoscopy which we published 10 years back. You can see small robotic arms attached to the endoscope. You can see it there. And as these arms are moving, you can actually remove large tumors. And this was a study where we showed that tumors which take normally about say 8 hours of resection, of course Mohan here is an expert, you saw him yesterday doing ESD in 15-20 minutes, but for somebody like me this will take much longer time, and you can see using this robotic system I could do this procedure in 7 minutes time. So these systems are now coming. Already there is one commercially available, 2 more are due to come in the end of this year, and soon we are going to have robotic flexible endoscopy, where in fact you can see in this case the operator is sitting here. This is Dr. Pradeep, our surgeon, endoscopy sitting and operating. I am just holding the scope, that's all. We can actually do endoscopic surgery. I can do surgery sitting in Hyderabad in a patient in Ranchi, or vice versa. You can sit in Ranchi and do surgery somewhere in Hyderabad or Delhi. So these will become possible in next 1 or 2 years, because already possibility is being seen. The other area where there's been dramatic enhancement is image enhanced endoscopy. As again yesterday you saw this narrowband imaging where we could see very clearly, even a distance from Hyderabad you could make out malignancies or tumors and so on. Other companies have so-called LCA and all, but all this enhanced imaging is going to lead to better techniques to see very early lesion. In fact, we now have endocytoscopy. We are about to demonstrate that before because the time was up, so yesterday we couldn't. But we have several other new technologies where you don't have to take biopsy. We have virtual biopsies. We can actually see the lesion. We don't take biopsies now. In fact, if you see a potentially resectable lesion on endoscopy, biopsy is contraindicated. Just imagine how much we have come from long over this period of time that biopsy is contraindicated. You should not do biopsy. You should resect the tumor and take it out completely. So this is the advantage. And of course, artificial intelligence is going to come in a big way. You can, this is called computer-aided detection and computer-aided diagnostics are coming in a big way. And this is actually seen, this movie is so good. This is Dr. Kudo. I think some of you have seen him when you came to our workshop in Hyderabad. He has developed this endo-brain. So in this endo-brain, you don't have to actually know how to do the procedure. All you have to do is, in the endo-brain itself does the procedure and gives you the diagnosis. This is, if this video plays, I can show you. Can you just? So what happens is you put the endoscope, put it on the lesion, and endoscopy will tell you whether you're dealing with malignancy or not, what is the percentage of chance of dealing with malignancy. So you can see here, me and Mohan are seeing this case, and we are putting as soon as the computer tells us, the endoscope tells us 94% chance that this is neoplastic. So you see, this is something which is again very unique, that we can actually predict which patients are likely to have malignancy and so on. We can. जो मैं स्टिक है ना वो लगा दे तो डायरेक्टली स्टिक से प्ले कर सकते हैं। मेरा है मेरा नहीं, मेरा दूसरा। I think my stick is somewhere there, so you can play directly so that it comes. Yeah, I gave it to. They loaded now, no? Some are working. Yeah, I gave it some. So the future is going to be what is called molecular bioendoscopy. That is, this is a clear example of how we can give some molecules to the patient and do endoscopy. These molecules go and stick in these early cancers. And even before the pathologist, we can make out a diagnosis in these patients. So this is going to be the future, and you can see here. The other, my stick is, the other major advance that has occurred is the new endoscope that we have now has got new types of light, and this light is called the amber light. You can see this amber light here. So this light will now actually enhance what we are going to see. And you can see this light penetrates down into the blood vessels, and you can actually see this dichromatic imaging, it's called. And we have now recently published where we can visualize these deep vessels with this dichromatic imaging, and then we can actually avoid these vessels when they are doing resection so that problems don't occur. So this is a new, again, advance that's occurring in this area. The other thing you see, I think we can play directly from here. No? Yeah, if you play directly, then the other area of advance is spiral enteroscopy. Yesterday in the endoscopy workshop you saw, you can put here. Then you can get the videos, lot of videos now. Now it's coming directly from here.
सारा उसमें embedded है.
Embedded. और उससे प्ले कर दे तो
डायरेक्ट
ये
PowerPoint.
डायरेक्ट आ रहा है उससे. Anyway, I'll at least show the image. It's very difficult to do an endoscopy talk without videos, but let's see what happens. So this is the spiral endoscope we saw. So the technique of seeing the small bowel now has changed dramatically. Yesterday you saw small bowel endoscopy from AAG. We can see the whole small intestine very easily. You can enter the small intestine very easily and see the whole small bowel. In fact, we have published a large series now using this endoscopy. We can go very easily into the small intestine, and I think again Mohan is an expert in this area in the world, very large experience. The other new scopes that are coming in is this spice scope. With the spice scope, you can actually go direct into the bile duct. Again, we have shown yesterday how you can identify tumors, how you can actually do direct therapy with lasers and all. And these are two lesions which on cholangiogram they look like they are just strictures, but when we actually did a spike cholangiogram, they turned out to be, you can see this very nicely, this was a lymphoma, and the right one was a tuberculous caseous lesion, and both these responded dramatically to medicine. Otherwise, surgery would have to be done, and these patients would have been subjected to radical surgery. So see how effective these are in terms of diagnosis because of this new modality of cholangioscopy that has come. So in addition to the new scopes, a lot of new accessories are coming up. For example, we have this new gel, the Korean gel. You can spray it directly on the bleeding area and the bleed immediately stops. And also when we do ESDs, delayed bleedings are there. And to prevent these delayed bleedings, we can actually spray this and keep it. So after 3 to 4 days, no more bleeding occurs. So these are all again new technologies that are coming. The other area where we have made a dramatic progress, again something you have seen in yesterday's workshop, is the advent of metallic stents. Like the cardiologists are using metallic stents for all their cardiac problems, we are completely switched now to metallic stents. We are no longer using very less of plastic stents, and you can see that even for very advanced patients, plastic stents are now being very, very less used. We now have a variety of new metallic stents, and some of this you saw yesterday, where in patients both with benign strictures, in malignant strictures, in pseudocysts, in walled-off necrosis, for everybody we're using these metal stents. More progress is occurring, and this is a new type of stents that are coming called biodegradable stents. So you can put the stent and forget about it. The patient will dissolve the stent automatically. Mainly now we are using for benign biliary strictures. In future, these are going to become more and more prominent, and you can, we have of course again worked a lot on this and published this type of stents which you can see here. This is a stent which can be put inside, and what happens is again this video doesn't play, but this stent expands, and over a period of time it will dissolve spontaneously, so there's no need to take out this stent. So we are also now progressing further in a patient who had a cholangiocarcinoma, for example. Earlier we used to just do endoscopic therapy, just put stents and leave them for palliation. But now we can actually do additional adjuvant therapy, and one of the things again you saw yesterday was radiofrequency ablation. We can do this radiofrequency ablation using this small catheter, and this is an example of radiofrequency ablation in these patients. We can completely ablate the cholangiocarcinoma, and now many of our patients with advanced cholangiocarcinoma are living for many years together. I have patients who have now followed for 5 years, 10 years cholangiocarcinoma because they have had this radiofrequency ablation. You can see that on radiofrequency ablation, this very villous tumor, once we do this, becomes completely white, is charred, is completely destroyed. So therefore, as gastrointestinal endoscopies have gone beyond just palliating, and see how the whole thing becomes white in these patients, completely clearing this. So this is again advances that have occurred in this area that we are now using. We are also using new devices, and this is a device called Speedboat. Again, Mohan is one of the world's authority in this Speedboat device, which we used to do POEMs, ESDs and so on. So a lot of new accessories are coming. This is a device called full thickness resection device. Earlier on, as gastroenterologists, we could not do full thickness resection of the GI tract. Now we can do with this device. And this is a device called the GERD device for reflex, very common. Patients used to go for surgery, but no longer necessary using this GERDX device. Again, this is something you saw in our workshop yesterday. You see how we are doing this device. We can put a small pediatric scope through the device, watch what is happening, and actually do surgical staplers, full thickness staplers. This is possible now. So in patients who have resistant gastroesophageal reflux disease, who don't respond to PPIs, who have a volume reflex, we're now subjecting these patients to this procedure, and they get fairly good dramatic response. And you can see this is a simple outpatient procedure and how this stapling device works. So all advances that are occurring in these areas, and we have published a large paper in Gut where we showed in a sham control trial, this GERDX device is extremely useful in PPI dependent patients who can't take PPI for some reasons. We can convert to a non-surgical treatment. The other area where advances are occurring is in endoscopic ultrasound. Endoscopic ultrasound is rapidly replacing percutaneous drainages or what surgeons used to do. We can now do biliary drainages using transgastric route or using the duodenal route. And also as a primary drainage procedure, this is becoming more and more common now. So a variety of new techniques. Even the gallbladder, we can now enter endoscopically. It used to be a surgical domain, but you can see here that we put a small stent attaching the gallbladder to the stomach, go through this stent into the gallbladder, where we can remove stones. We can do an ESG in the gallbladder also. All this can be done. And this new era of gallbladder endoscopy is going to pick up, so that the gallbladder, which is a predominantly surgeon's domain, is going to become an endoscopic domain now. So the other area is, of course, bariatric endoscopy. This is becoming now more and more popular, and you can see here a bariatric endoscopic procedure called endoscopic sleeve gastroplasty. Endoscopic bariatric procedures are now competing with laparoscopic bariatric procedures, and there is some evidence to suggest that this is not only easier, more outpatient technique, but the success rates are similar, and therefore there is a trend towards these endoscopic procedures like sleeve gastroplasty, for example, that is being increasingly done now. The most exciting area of endoscopy is called the metabolic endoscopy, and this is the future. Now, what is metabolic endoscopy? Metabolic syndrome, for example, NASH, hypertriglyceridemia, hypertension altogether constitute metabolic syndrome, are traditionally treated with medicines, and many of these patients we don't have adequate treatment. But a new discovery has shown that in the duodenum, second, third and fourth part of the duodenum, there is an insulin resistance factor. If you can destroy this insulin resistance factor by whatever technique, then you can reverse the metabolic syndrome. And this is very exciting discovery. Probably somebody will get a Nobel Prize for this when they discover the actual insulin resistance factor. But what we can do endoscopically is to remove the second part of the duodenum mucosa, and the new mucosa which generates does not have this insulin resistance factor. And these experiments in mice showed that this was possible. Very elegant experiments in mice have shown this, that this is possible. And of course, larger animals like swine also this has been done, where injection to the submucosa and the mucosa is destroyed. And these diabetic animals again become porcine model, become non-diabetic. And of course, we now have very exciting work in humans being, it's called the duodenal mucosal resurfacing technique, where you can put an endoscope inside the second, third part of the duodenum and then inject some submucosal saline to lift the mucosa up, and then using a hot water balloon destroy the mucosa completely. So this duodenal mucosal surface procedure is a few years old. We now have data in over 1,000 patients suggesting that type 2 diabetes is being reversed in these patients. It's a very simple technique, and this is now something that is going to be the future. And you can see that the mucosa which is destroyed regenerates within 3 months' time. But what regenerates is normal mucosa, not the neuroendocrine part, which actually secretes this insulin resistance factor, and therefore these patients reverse. We have some very exciting data, and this is actual video showing. I had an opportunity to work in Brussels with some of these devices, and you can see the actual device. Now it's a balloon which we inflate in the second, third part of the duodenum and inject this submucosal substance, and then put the balloon with hot water around that area, and the mucosa gets destroyed. There are simpler devices now, laser devices and so on coming, which are concentrating this area so that type 2 diabetes can be treated. And this is a huge load of patient volume that endoscopy is going to see. See how it becomes all whitish? This mucosa regenerates, but the new mucosa which is formed does not contain this insulin resistance factor. So a variety of studies have been done, and this is the first study called the Revita study, where you can see that there is a drop in A1C by 1.5 points, which is very, very high. For the drug to be approved, even 1 is enough, and 1.5 you can see this. And not only that, but hepatic functions also improve, and these patients reversal occurs. And this is a very, very interesting study which was done in Netherlands, where patients who are dependent on insulin underwent this procedure, and by end of this 3 years, over 53% of the patients were off insulin completely. You can see how effective this is going to be. And of course, we now have evidence to suggest that not only does it correct glycemia, it improves hepatic indices, and this is the only procedure which has been shown to reverse NASH. Patients with NASH, the fibrosis comes down, enzymes come down, progression to cirrhosis does not occur. And of course, lipids get corrected. So this is a huge advance that's occurring in metabolic endoscopy. And what is going to happen in the future is that gastroenterologists are going to be also endocrinologists. Or alternatively, endocrinologists have to learn endoscopy to survive, because the large chunk of patients are going to now come into the field of endoscopy. And of course, coming to the last area, this is third space endoscopy. Again, we have Mohan, who's one of the world's experts in this area. Poem, poet, and again you saw poem being done yesterday, how it is done. This is a technique which in fact more than 10 years back we first propagated. This was a patient who came to us with anterior abdominal wall burns. We couldn't do a regular appendectomy. Me and my colleague Dr. G.V. Rao, together what we did is we went through the mouth, made an opening in the stomach, and then cut the appendix, the inflamed appendix, and took it out through the stomach opening. And you can see the appendix coming out. We pulled it out through the opening in the stomach and through the mouth. So this was the first human appendectomy done through the mouth. In fact, at that point of time, people didn't believe us. Of course, everybody was surprised that this could be done. And subsequently, notes came and a lot of procedures were done. Unfortunately, notes couldn't go further because instrumentation was not available. What is now transformed from nodes into third space endoscopy is the benefit of all the techniques that are developed at that point of time. We now are again going back to nodes. Using the flap technique, we can go get into the peritoneal cavity, and endoscopy can be done in many of our patients by this. And the future again is going to be navigation surgery. In fact, if you look at what is happening to in orthopedic surgery or neurosurgery, in our hospital we have a big navigation screen. Our neurosurgeon is going, watching the navigation screen and then doing surgery. We hope that in near future the endoscopists can also do this navigation surgery, where we can have everything planned by MRCP and CT scan. We can go to the area where we want to do, go to the for example, ERCP, and then do a sphincterotomy, avoiding all the blood vessels, because already we know the navigation where the vessels. We can enter into the liver, go to the area where we feel there's a small tumor there, and do a radiofrequency ablation. Similarly, we can open up necrotic areas, suction out all the walled-off necrosis and so on. All these, again, in my opinion, are going to come very shortly, because this technology is already available to us. So, what is happening is that all these technologies are disruptive technologies which are breaking the barrier between surgeons and physicians. When I did my DM, I think BK also will remember that at that point of time, endoscopy was done predominantly by gastrointestinal physicians, and then slowly surgeons came in. At one point of time, I think Satish was one of the leaders surgeon endoscopists here. They have also started doing, and there used to be a big turf war between who should do procedures, surgeons, physicians. This is completely broken now. The barriers are broken. Anybody who's good with his hands-eye skill can become an endoscopist. There's no more physician endoscopist, surgeon endoscopist. All are endoscopists who are good at doing the procedure. And this disruptive technology is going to go forward, so that a new specialty of gastrointestinal endoscopies, where both physicians and surgeons will be doing, will come into being. In fact, when I went through this talk, you can see that I said future of endoscopy, but 60% of what I showed you is already what we showed you yesterday in our workshop. This reminds me of what Einstein said in 1929 when somebody asked him, what do you think about the future? He said it will come soon enough. And in endoscopy area, it has come soon enough. The future is already here. Many of the so-called futuristic procedures we thought we'd see 2 or 3 years back are already available with us. And in next 5 years, gastrointestinal endoscopy is going to be dramatically, radically changed. And for those of you who are postgraduates or entering or going to enter into gastroenterology, this is one of the most exciting fields in medicine today, because you're standing on a threshold of these dramatic changes. And soon our practice of gastroenterology is going to be different from what we have been doing. And again, to see some of these changes, I'd like to invite you to our annual EndoCon, which is the annual conference of SGI. This will be the first large physical meeting of our national society, and I hope I'll be able to see many of you during this period, where 30 international faculty are going to demonstrate many of these futuristic technologies. Thank you very much for your attention.
Thank you, Nagi, for an excellent talk, what is going on and what is in the pipeline in the future. I think nobody has seen future, but we predict, and I think what we predict, we see more than that. So that way we are very lucky that we are having you here and hearing your talk. And since this is an oration, we are not accepting any questions here. So once again, I thank Nageshwar Reddy for this excellent talk.
Thank you.
Lovely called as Nagi.
We welcome the chairpersons to felicitate Dr. D. Nageshwar Reddy, sir. Big round of applause, everyone. So proceeding with the next session, we have Dr. Mohan Ramchandani sir with us. The chairpersons are Dr. Sangeet Saurav sir, Consultant Gastroenterologist Ranchi, and Dr. K.S. Narayan sir, Consultant Gastroenterologist Bokaro. Dr. Soumya Ames. Dr. Supriyo Ghata. We would ask the chairpersons to welcome sir.
So our next speaker is, as we all know, Dr. Mohan Ramchandani sir. He is a consultant gastroenterologist at AIG with a vast experience of almost 18 years. He is an alumnus of prestigious BHU, trained in the field of therapeutic endoscopy in India and abroad. A special interest, as we know, and we saw yesterday also, third space endoscopy. Recognized expert in this field, passionate teacher and interested in research, and has many publications. So today he will basically teach us on management of biliary strictures. I think a very important topic that we encounter in our day-to-day practice.
Okay. At the outset, I thank organizing committee, especially Jayant, Dr. Manohar, for giving me this opportunity. I think after Professor Reddy's talk, I think this is more basics. And day in, day out, we see these biliary strictures, and we don't know basically why these are coming. Most of the time, we are depending on the indirect fluoroscopy pictures. But my talk should have been like management of the disease which is responsible for the stricture. It's not just like a plumbing job where we want to just get rid of the stricture. But I think we should ask ourselves many questions. Why this stricture is there, whether the stricture is benign or malignant, whether it is operable or not operable, whether the strictures before operation needs a drainage so that the post-op complication may be less. What are the options available to treat these strictures? If we say this stricture is malignant, then it's not operable. What are the adjuvant therapies? So there are many questions we should ask ourselves whenever we see a patient of a jaundice who has obstruction because of these strictures. Because there are no more differentiation between malignant and benign. Because malignant stricture may require surgery or may be cured, as Dr. Reddy showed a case of lymphoma which is malignant but treated by another modality, it's not surgery. Similarly, benign disease, it's not just benign disease. What benign? Is it IgG4 disease which can be cured by steroid, or it's a tubercular stricture which will require anti-tubercular treatment? So we should go into the depth of why the stricture is come before we start managing. And we should always divide these strictures, whether the biliary stricture is proximal or distal. If the distal stricture is there, most likely the stricture is originating either from pancreas, and our choice of treatment will depend on the stricture where we are dealing with. Say, for example, ultrasound has shown dilated biliary system with an obstruction at lower end. Our next step should be do a CT scan rather than MRCP. MRCP is good for proximal strictures where we need a roadmap to do ERCP or to say whether the tumor is operable or not. But if it is a lower CBD stricture, I will go ahead with a CT to see the operability, whether there is evidence of cancer on imaging itself. So all cancer won't require surgery or pre-operative biliary drainage. And a stricture which is quite evident on transabdominal imaging to be a cancer and it is operable and the bilirubin is not very high, you can straight away send these patients for surgery. So that is important to have a clinical clues. So we should have a clinical clues, a patient who has young, who has history of pancreatitis, who has normal CA19-9 or high IgG4. These have prior pre-test probability of being a benign stricture. And our aim should be to diagnose these cases, and our threshold for surgery in these cases will be low. We will do more investigation to confirm the malignancy. While if there is a concerning things like a heavy weight loss, there is high tumor markers, there are prerequisite predisposing conditions like PSC, the stricture is long, there's asymmetric strictures, these are choledochal cysts which are prone to cause malignancy. If these things are there, we will believe a pre-test probability of malignancy is high. So in such cases, whenever we encounter a stricture, we'll keep a very low threshold. We'll tend to send these patients for surgery. And before embarking on anything on strictures, say for example, don't jump on ERCP. Just have a look on a good CT or transabdominal imaging to classify the bismuth classification, see if there is any atrophic lobe, whether there is a vascular involvement in the form of portal vein or hepatic artery. Just see the abnormal anatomy. And then you decide whether I need to do how I'll proceed for biliary strictures. And the most common indication patient being referred for us for biliary stricture is for ERCP, and then I will do many tests including the ERCP with better tissue acquisition. I want to know whether the stricture is malignant or benign, and these are some of the very common thing which we use. We use breast cytology or biliary biopsy, but there are very few, the sensitivity is high, and then there are many false negatives, and then we are able to diagnose almost 1/3 of patient correctly. The sensitivity of breast cytology at the most is 45%, or combination if you use around 55 to 60%. That is why we have to use other modalities to correctly diagnose these strictures, including the cholangioscopy. And the cholangioscopy is the one which gives us an opportunity to go inside the bile duct and see the image criteria. And this was the first paper from Nimuara who described these tumor vessels. And the tumor vessels are present in 70% of the malignant strictures, but 0% of benign. So if tumor vessels are seen, then you can diagnose these strictures as cancer. So that is why don't only depend on breast cytology or biopsy, do additional tests. And there are certain varieties of cancers, including infiltrative variety of cancers, where the breast cytology or biopsy rate is almost 10 to 12% because of the strong fibroblastic reactions, and then the cells won't shed. And if you, how many breasts you do, you will get nothing. So that is why we use these modalities, and by just mere seeing, by visual impression, you can have like this patient who has a stricture, and you can see a very thin hole over there and lot of scarring. So this is a benign stricture. So there is a scarring, there are no tumor vessels, so clearly benign. Similarly, if you see such tumorous infiltrative tumor vessels, you can see the moment you see these tumor vessels, it is almost 100% sure that you are dealing with a malignant disease. No need to take even biopsies. That was about the visual impression. You can do more image enhancing cholangioscopies like this to see whether there is tumor vessels which are better seen by narrowband imaging. And this was the paper which was recently published, has shown the accuracy increase from 82% to 91%. So image enhanced endoscopy is also being incorporated in cholangioscopy to improve the diagnosis. Now once you see a stricture, you need to take biopsies. And there is a method of taking biopsies from these strictures. You have to go from below upwards, take biopsies, and handle these biopsies very well, because the biopsy material gotten is very small. How many passes you make, you can take imprint cytology then and there itself, right in the endoscopy room, like we do in endoscopic ultrasound. This is known as tissue imprint cytology, where you can have immediate answer by our pathologist. As you have seen yesterday in our live demonstration, Anuradha gave us diagnosis then and there only, and that was a complex stricture, and we had to make a decision whether we'll put a plastic stent or a metal stent. But since the patient was inoperable, with a diagnosis in our hand right in the room, we can send these patients for a metal stenting. And this was our paper which has clearly shown that if you use this technology to diagnose, so that's my message. Don't treat biliary stricture as a stricture, treat it as a disease, find the cause and treat. And this type of technologies help us in diagnosing these cancers in very well. And once you have made a diagnosis, now we are on the, say for example, we have made a diagnosis of cancer. Then it comes question, what stent to be put, how many stents to be put. So that there is no question now about metal stent or biliary stent or plastic stents, because there are a lot of meta-analysis. This is a big meta-analysis published recently, 20 randomized control trial, 1,700 patients, clearly shown that metal stents do well. Even the initial cost of metal stent is high, but if you see overall management of the patient coming with recurrent obstruction, cholangitis, metal stents do well. They have longer stent patency, lower complications, lower reintervention. And in some settings, there is a survival advantage too. And we can clearly see the metal stents last for 7 months, while the plastic 7 French stent will last for maximum 8 weeks. The question regarding which stent to use, metal stent covered or uncovered, for uncovered, for all hilar strictures, for distal strictures, it is the covered metal stent which scores over the uncovered metal stents. The question regarding how many stents you have to use, always see the MRCP. Don't jump on ERCP immediately. Do an MRCP, see a roadmap, what type of stricture you are using. And also see a CT scan. A CT scan should be seen to delineate whether there is a right posterior duct, right anterior duct, or left duct. Each system drain around 30%. And it is also important to see the CT scan to see the lobar atrophy. If the lobe is atrophied, don't drain this. You will drain nothing, but you can cause cholangitis. So always see the lobar atrophy and decide which type of stent to be placed. And as you see, when you see an MRCP, you can decide whether you are dealing with a type 1 stricture or type 2 stricture. If there is a type 1 stricture, right anterior, right posterior and left system are communicating, only one stent is enough. While if you are dealing with type 2 strictures, when the right system is separate from posterior, a single stent on the right side will then 30% plus 30%, more than 50% is required. So one stent on right side will be enough. While if you are dealing with type 3A strictures, when the tumor has gone to the right side, separating right anterior and posterior system, then you have to place at least 2 stents in the one left or one right anterior, or one stent in right anterior or one right posterior. So this is how you decide based on MRCP how many stents to be placed. So metal stent always, the stent, how many stents to be decided based on transabdominal stent imaging, especially to see the lobar atrophy. Don't go into the atrophied lobe and decide about that. Type 4 stricture should be managed by PTBD. And not only this, metal stents are not enough now. We have enough evidence showing the use of adjuvant therapy. If you do some adjuvant therapy, like radiofrequency ablation, it is not just burning, it is also the immunomodulation. There is a lot of cytokines coming up, which will attack these tumor cells. And once you add adjuvant therapy to the stent, the survival improves, the quality of life improves. There may not be any added advantage on stricture diameter, but there is definite survival advantage. And PDT has been used since long, that photodynamic therapy, but it is not practicable in India. In India, we use radiofrequency ablation, and both the modalities are equal. Technique is very simple, just like a catheter. You burn the tumor. There is no photosensitivity, and there is a very good evidence coming up now showing in randomized controlled trial that these strictures can be managed much better if you add adjuvant therapy to the stent. Regarding benign, as I told, spend more time in deciding what is benign, what is malignant. And then once you have a benign disease, especially post-cholecystectomy, chronic pancreatitis, treat aggressively. Use multiple stents, no single stent. You have to keep on dilating these strictures by multiple stents, and then once you place 4 or 5, 10 French stents for 1 year, it keeps the stricture dilated for long, and it opens up the stricture. And that is the advantage of using multiple plastic stents. You can treat this stricture by removable metal stent, that is fully covered stent. And we have published a randomized controlled trial in gastroenterology recently, which has shown if you are treating benign biliary strictures, metal stents are equally efficacious to multiple plastic stents, but metal stents require much less number of ERCP, because if you place once, the patient will come back after 6 months. So that is the advantage of fully covered stents in benign biliary strictures. Future trends, there are drug-eluting stents coming up. There are these stents are impregnated with anti-cancer drugs, especially paclitaxel, that blocks the proliferation of fibroblast, and the stents remain patent for a long time. We are now coming up with 3D printed stents, and these stents are impregnated with plasma mesenchymal stem cell. These are placental derived mesenchymal stem cell. If you put into the stents, these stents last longer. And biodegradable stent, you need not to remove the stent. These stents dissolve. These stents get digested and convert into hydrogen and CO2. And the material which we use is polydexagonal or lactic acid. Depending on the material, the stent will dissolve. Say for example, PDX, it dissolves in 3 months. And these stents can be designed in such a way, say for example, if you are doing a ERCP and your wire is going again in PD, you put a biodegradable stent which dissolves in 3-4 days time. So patient will not come back for removal of prophylactic PD stent. Similarly, cystic duct leak. you can just put a stent which will last for around 8 weeks. Your leak will resolve and patient will not require additional visit to hospital to remove that stent. We are also now using artificial intelligence in diagnosing these, and with the push button technology, endo-brain technology, you can just attach it to cholangioscope and the computer will tell you whether this disease is benign or malignant. So with this advent of many new modalities, ultimately I think biliary stricture treatment is a team game. It requires surgical opinions, interventional radiology opinion, and also gastroenterologist opinion. And with this teamwork, I think these type of complex biliary strictures can be treated. But my message is, don't treat strictures as a plumbing or a stricture as a physical stricture. Treat it as a disease, identify the disease which is causing this, and make a plan along with surgical colleague whether the surgical correction is required, or once you are decided palliation is required, or whether the benign biliary stricture is amenable for endoscopy or not. In such way we can provide the best outcome to our patient. And thank you very much for your patience here.
Thank you, Mohan sir, for such an excellent talk. Although your talk was regarding the management of biliary strictures, my doubt is, sir, is, as you know, US FNA has become the modality of choice for biliary stricture diagnosis. Sir, how common is tumor seeding of needle track while doing US FNA? Can you shed some light on it?
So there are two things. One is, as I told, whenever you are seeing a biliary stricture, say whether it's a distal or proximal. If the distal tumors are there, mostly they are extrinsic to bile duct. Say for example, pancreas, see a pancreas. In such cases, once you do Whipple surgery, you remove the needle track also. And that's why the EUS guided FNAC is a best for lower CBD strictures. For higher strictures, if you want to do an aggressive surgery, even Mayo protocol, they say that if you do brachytherapy and reduce the staging of tumor and make these patients amenable for liver transplantation, they also exclude EUS to be done to go into that track and take the FNAC. Though it is theoretical, but yes, EUS guided FNAC may not be an ideal for hilar stricture, but it is ideal for lower CBD stricture.
Sir, it's nice to hear audience. I am Soumya from All India Institute of Medical Sciences. I have two questions. Number one, so in benign hilar stricture, which type of stent would you prefer? Number two, in high up stricture, mid CVD or hilar stricture, when will you do a cholangioscopy? So in which type of cases? And would you do cholangioscopy during first ERCP or subsequently?
So excellent question. Actually, I'll answer the second question first, because we recently published a trial in randomized control trial in GIE, which shows that if in our protocol, we find a stricture, we take breast cytology, put NBT or stent, wait for 5 days to 6 days for the result to come, and we are waiting for a 30% positivity, and that ultimate come negative. Again, we bring the patient, do again breast cytology, biopsies, this time more aggressive biopsies, again wait for 4-5 days. A patient coming far off in our country, staying for 10 days in Hyderabad, say for example, and this increased the frustration of patient as well as for surgeons or diagnosis. We are not able to if in that situation you do first cholangioscopy, don't do anything, you don't have stent induced changes, you have straight away nave papilla, and you are using a cholangioscope which we are reusing, so it is more cost effective to have first cholangioscopy, have a proper dilatation, and that showed much more cost effectiveness, no radiation. So we are, with the advent of these plug and play type of cholangioscopes, we are seeing in future that a first cholangioscopy, rather than depending on these breast cytologies, will be a future. That has been proven, but as of now it is not standard. As of now we do brush and biopsy, and if first is negative we do cholangioscopy, otherwise not. And also we take care of type 4 strictures. If there is a type 4 stricture, there is separation of all intrahepatic ducts, you do cholangioscopy, you instill saline, you cause cholangitis. So we make sure that type 4 we exclude, and we don't do in that. In that we do PTBD, and through the PTBD we come back and do the cholangioscopy. That will prevent the cholangitis. While regarding hilar strictures, benign strictures, we cannot use fully covered stents. We still have to depend on multiple plastic stents to get rid of these strictures.
Sir, I have a question. In cities or places where facilities of cholangioscopy is not available, your advice on judicious use of PET scan, if any, in indeterminate biliary strictures?
Yeah, so that again is a very important question. So the hilar strictures of many varieties. There's like papillary type, or there's a tumor forming type, or there's an infiltrative variety. So indeterminate stricture gives negative in infiltrative variety. When there is no mass on CTE, there is only thickened bile duct, and then if you do brush, that is also negative. In that, the PET scan positivity is only 20%. So PET scan is not like a holy grail. It has got limitations, and it has got limitation maximum, where the limitation is there for endoscopy and trans-abdominal scanning. So PET scan is not the answer at all. I feel so. We do a lot, and that is very important. If you have a good sphincterotomy, you can have very nice dedicated biliary biopsies available, especially from Olympus. There is a black catheter biopsy which goes very smoothly. And only thing is sampling error. You may hit in different site and you may have a false negative. But the advantage of cholangioscopy is you have no sampling error. Whatever you take is from correct site. So that if you can add, say for example, 10 biopsies, those sampling error will reduce. And you can innovate some things, but fluoroscopic guided biopsy is a valid answer to that, definitely.
Dr. Mohan.
So for plastic stents, for metal stent, we give 1 year chance. So our is the 1 year chance. If you are not able to open the stricture at 1 year, don't prolong it, because the patient will go into secondary biliary cirrhosis. So if 1 year, you do 6 months removal, do a good balloon sweep. If the balloon is coming out, wait. Keep patient in very close follow-up, every 2 month LFT. If the patient has a reformation of stricture, then don't drag this. Don't put more stents. Most of the patients, 70% will resolve, but 30% won't. So these patients require proper bilioenteric anastomosis by surgery, and that will prevent long-term prevention of secondary biliary cirrhosis. So it is important to call these patients at 6 months, remove the stent, see the stricture. If stricture persists, another metal stent for 6 months. That's all.
Dr. Mohan, very nice presentation.
Thank you.
I'm Dr. Ghatak from Kolkata. For just a second, I think you alluded to the fact that you refer for you get referral for preoperative biliary drainage in Whipples when the bilirubin level is high. So is there any cutoff? Actually, we don't do that. I mean, we don't have any such cutoff, and we do Whipples in any bilirubin level. So do your center have any specific cutoff?
Yeah, so there are 2 settings where our center have. So there is now a lot of data coming on neoadjuvant chemotherapy. So all operable cancers of even pancreas, which are borderline operable, say for example there is a 180-degree contact with superior mesenteric vein, our surgeons say will give neoadjuvant therapies. In such situation, we put metal stents. Otherwise, our surgeons are now becoming more aggressive. Previously, we had a request from surgeon coming up when the bilirubin is about 10, they want a preoperative biliary drainage. But with the recent thing, our surgeons are also accepting patients with high bilirubin, but not for hilar strictures. Hilar stricture, once the major hepatectomy is required, they are doing the future remnant, the volumetry, and if the volumetry is not proper, they are asking us to drain, and also portal vein embolization. In such situation, we are draining this. But for distal biliary strictures, the almost cutoff is not there, which is gradually evolving. Previously, 10 was there, but gradually they are more aggressive. But neoadjuvant therapy, it is almost required.
Sure. In hilar stricture or in liver resection, it is imperative that you have to get preoperative biliary drainage.
Yes.
That is still universal.
Yes, yes.
Can I add to questions of Dr. E? So for lower end biliary obstruction, usually at our center we keep it till 12 to 15. If bilirubin is more than 15, post-operative infective complication or other complications are higher, so the surgeons want to put a stent.
But I think there are multiple trials on this, and there is no evidence for that. There is no evidence actually for preoperative biliary drainage for any level of bilirubin in
Yeah,
Whipple's.
but see that-
Not in hilar stricture, not in liver resection.
Yeah. So the trials are also associated with many fallacies, like NEGM paper, which we are talking about, randomized control trial between preoperative biliary drainage for distal CVD stricture. The complication of ERCP was 55%. So there is no 55% complication in a very high tertiary centers. So the trials have not shown properly, and as Dr. Saab is telling, there are a group of surgeons who would really want biliary operative drainage to be done pre-op above 15, or some may ask about 10. But of course the literature is there, but one can discuss a lot about the literature. Why there is so much complication of 55 to 60% in ERCP arm. So there are other things also.
That is a topic for debate, I think.
That is a gray zone, sir, I think. And thank you very much, sir, for such a nice talk and discussion.
Thank you.
Thank you, sir. Now I would request the chairpersons to kindly present Dr. Mohan, sir, with the memento and the shawl. Sir, please. Would also like to request the organizers to kindly present the memento to the chairpersons. Moving on to the last session, Dr. Tanmay Maji sir will be the speaker, and the chairpersons for this session will be Dr. Anand Kumar, Dr. Antriksh sir, Dr. Vijay Kumar Mishra sir, and Dr. N.C. Sinha sir. So please.
Dr. Tanmay Maji. He is a second-year DM gastroenterology resident at AIIMS Patna. His topic is post-COVID-19 steroid refractory ulcerative colitis.
Excuse me, Dr. Vijay Kumar sir, who is a consultant gastroenterologist from Jamshedpur. He is also invited on the dais.
Ring. First phase. फुल नहीं कर सकते
हो जाए सर, स्लाइड साइड होंगी जी।
Good afternoon, everyone. I am going to present a case post-COVID-19 ulcerative colitis. COVID-19 usually caused by SARS-CoV-2 virus, globally pandemic for last 2 years. Post-COVID-19 autoimmunity is proposed, a transient immunosuppression in which self-tolerance is lost, an inappropriate form of immune reconstitution that amplify the process. In SARS-CoV-2 infection, patients have developed many autoimmune conditions like systemic lupus erythematosus, Guillain-Barré syndrome, and many others. Various GI symptoms like anorexia, diarrhea, vomiting, dyspeptic symptoms develop during and after post-COVID infection. And there are some data showing post-COVID-19 inflammatory bowel disease. Hence, we have also encountered such case at that time. Coming to the case history, 34-year-old lady without any previous comorbid illness presented to us with a history of bloody diarrhea for last 30 days. And patient was apparently well 1.5 months back when she developed mild COVID-19 infection and was on home treatment. 1 week after his recovery from COVID-19 symptoms, she developed diarrhea, which was insidious onset and frequency was 10 to 12 episodes per day. Each stool associated with blood, she has history of tenesmus, crampy lower abdominal pain, and low-grade fever. She had no history of extraintestinal manifestation of inflammatory bowel disease. Patient is evaluated outside for above complaint, and she was treated as infective colitis with broad-spectrum antibiotic and antiparasitic drugs. But her symptoms were not relieved after taking treatment for 14 days and referred to AIIMS. These are the available investigation which was shown at the time of admission. CRP and ESR was quite high, 74 and ESR was 45, and stool for C. difficile toxin, stool RM, ovocyst, all are normal. Sigmoidoscopy which was done outside showed mucosal erythema, ulceration and friability and multiple pus flakes suggestive of hemorrhagic colitis. On examination at presentation, abdominal tenderness present on left iliac region and deep palpation. So after diagnosis from history, examination and investigation, post-COVID-19 chronic diarrhea, large bowel type, inflammatory, etiology most probably inflammatory bowel disease, ulcerative colitis, and second DD was infective colitis. In view of chronic diarrhea with symptomatic worsening and no response to antimicrobial, a presumptive diagnosis of inflammatory bowel disease, ulcerative colitis was made, and she was started on intensive regime. In the meantime, a biopsy report had came, which was done outside, which was shown chronic active colitis in the form of cryptitis, crypt abscess, crypt architecture distortion, and basal plasmacytosis. After 3 days of IV steroid therapy, patient stool frequency decreases 6 to 7 from 12 times per day, but patient has still same rectal symptoms, and she was labeled as steroid refractory severe ulcerative colitis, and rescue therapy was planned. But due to financial issue, the rescue therapy was not given at that time, and we further given 4 days of steroid therapy. But after 7 days of treatment, patient didn't improve, and then also the stool frequency was 6 to 7 times, and all stool are associated with blood. At that time, we have some dilemma in diagnosis. Was it steroid refractory severe ulcerative colitis or an alternative diagnosis like CMV colitis? Because at that time, few case report was published throughout the world that hemorrhagic colitis post-COVID patient shown that CMV was positive. So patient underwent repeat sigmoidoscopy with biopsy, which was showing mucosal erythema, ulceration, loss of vascular pattern, and UCIS score was 7. Biopsy shown mucosal ulceration, cryptitis, crypt architecture distortion, crypt abscess, and in immunohistochemistry for CMV was negative, and PCR for CMV was also negative, and IgM antibody for CMV and serum was also negative, and CRP was 110. This was the CT scan image of CCT abdomen, which was shown that inflammatory changes on the left side colon. Now, on the 8th day of admission, patient was given injection infliximab in the form of salvage therapy. And on day 11, patient symptomatically improved. Stool frequency was 2 to 3 times per day, Bristol type 5 and non-bloody, and CRP was also come down to 6, and partial Mayo score at the time was 2. And patient was continuing infliximab every 8 weekly interval along with azathioprine, and she continued in remission, and 1 month ago she had received recent infliximab dose. Now come to the discussion, does COVID-19 precipitate underlying asymptomatic ulcerative colitis? If yes, does it cause steroid refractory severe ulcerative colitis? Some words regarding asymptomatic ulcerative colitis. Asymptomatic patient with colonoscopy picture of diffusely granular, friable or ulcerated mucosa with histopathological sign of chronicity. 2 large ulcerative colitis cohorts shows prevalence of asymptomatic ulcerative colitis with 1.1 to 2%, and majority of them become symptomatic within 5 to 10 years of follow-up. Asymptomatic inflammatory bowel disease detected during colorectal screening program in healthy population. This was the data showing different rate of prevalence of asymptomatic ulcerative colitis in different countries. In a large cohort in North Korea, among 19 asymptomatic ulcerative colitis patients, 12 developed symptomatic within a median time of 2 years. Pathogenesis of IBD in COVID-19. IBD is a multifactorial disease. Possible mechanism in IBD pathogenesis can be adaptive immune system cell response against self-antigen. Environmental factor like infection may trigger IBD, both ulcerative colitis and Crohn's disease in genetically susceptible individual. Angiotensin converting enzyme 2, ACE2 receptor is the key for SARS-CoV-2 virus to enter the host cell, and ACE2 receptor are vastly seen in GI tract, mainly in terminal ileum and in colon. So ACE2 receptor play a major role in intestinal inflammation and microbiota changes. This is the molecular pathway of COVID-19 infection with IBD. SARS-CoV-2 infection which bind to ACE2 receptor and further produce different inflammatory cytokines like interleukin 1, TNF-alpha, interleukin 6. Gut dysbiosis in patient with COVID-19. COVID-19 can cause gut dysbiosis, which can reduce in bifidobacterium, lactobacillus, and eubacterium, which are mainly butyrate-producing bacteria, and increase in corynebacterium and ruthenibacterium. This is a study done which shown that post-COVID infection, they are followed up to 6 months, and they have shown that increase in bacteroids, Proteobacterium, and there is decrease in Firmicutes, Acinetobacterium in patient of COVID-19 infection, then healthy population up to 6 months of the follow-up. And fecal calprotectin is another indirect inflammatory marker of gut epithelium, which is increased in any inflammatory condition. So in COVID-19 infection, fecal calprotectin level significantly increased in all COVID-19 infection who had GI symptom and who had no GI symptom. This is another study which has shown that patient with COVID-19 infection has significantly increased fecal calprotectin level, and it was not different in who has GI symptom and who has no GI symptom. And in COVID-19 infection, interleukin 6, CRP, and ESR is also increased, and there was no difference in the patient with GI symptom or no GI symptoms. So elevated level of fecal calprotectin may be related to the gastrointestinal inflammation in case of COVID-19 infection. Now come to steroid refractory ulcerative colitis. In contract cohort, response rate of IV steroid in acute severe ulcerative colitis was 49%. In one study, first attack of ulcerative colitis presented as a steroid refractory was 22.6%. In acute severe ulcerative colitis, patients should be assessed for clinical and biological response after 3 days of IV steroid therapy to determine the need for salvage medical or surgical therapy. No additional benefit beyond 7 to 10 days of therapy. These are the predictor of the outcome in acute severe ulcerative colitis. Most commonly used is Oxford criteria. When bowel movement is more than 8 times per day or 3 to 8 times with CRP more than 45 after 3 days of IV steroid therapy, then we have to plan for salvage therapy. And there is also other predictor like low albumin, CRP albumin ratio is 0.8 plus stool frequency more than 3 and different endoscopic predictor also. Different society guideline, they have also shown that the response to intravenous steroids should be best assessed by the 3rd day, and if there is no response, then we have to plan for salvage therapy in the form of surgery or cyclosporin or infliximab or tacrolimus infusion. This is short diagrammatic management guideline which is given by British Society of Gastroenterology. After day 3 of the treatment, we have to assess the patient if bowel movement is 8 per day or 3 to 5 per day with CRP more than 35. Then we have to review for surgical review for colectomy. If patient is fit for colectomy, then go for colectomy. If no, then patient is planned to give IV infliximab or cyclosporin. Recently, ulcerative colitis onset during and after the SARS-CoV-2 infection have been reported throughout the globe. And in my knowledge, around 8 to 9 total case report was published throughout the globe, and none of them require salvage therapy. Most of them respond with IV steroid and mesalamine treatment. To conclude, SARS-CoV-2 may precipitate underlying asymptomatic ulcerative colitis patient. Proposed mechanism could be ACE2 receptor overexpression, immune dysregulation, and gut dysbiosis. Post-COVID-19 steroid refractory ulcerative colitis, decision making for salvage therapy is crucial step. Thank you.
Thank you, Dr. Maji, for your excellent presentation. I also want to tell you that I also had a case of ulcerative colitis just like you had. This patient had suffered from COVID, became negative, but on doing the colonoscopy or sigmoidoscopy, he had frank ulcerative colitis. Now, second point I wish to raise is you did not give high dose of mesalamine rather than you had given steroids. But would mesalamine could have helped in this case? I don't know.
But sir, in acute flare, we have to prefer IV steroid, not mesalamine. Okay.
But along with mesalamine?
Yeah, but in acute condition, there is no role of mesalamine, maximum guideline of says. But so we have to give IV steroid. If it is fail, then go for salvage therapy. And we have discussed with patient for colectomy and other available treatment.
Okay, thank you. And any questions from the host?
What was the dose of steroid that you used and what was the X-ray like at presentation? You didn't mention about the X-ray abdomen.
Yes, sir. We have done X-ray
steroid
abdomen.
Dose.
Yes, sir. It is a protocol to do an X-ray when patient with acute severe ulcerative colitis. It was quite normal, sir. There is no toxic megacolon. Yes, sir.
Steroid dose. What did you give?
We have given 100 mg IV steroid 6 hourly.
What was the status when patient was treated with steroid during COVID treatment or not? Because many patients of COVID had received steroid.
Yes, sir.
So at that time he or she had received steroid or not?
No, sir. Patient has only mild COVID infection. For that, she had get only home-based treatment.
Any questions? Okay, thank you, Dr.
Thank you,
Maji.
sir.
Thank you.
For excellent
I would
presentation. once
request the
again.
chairpersons to kindly provide this memento to the speaker. Sir, please. And the organizing committee to kindly present the memento to the chairpersons. Thank you, sir. Sadhbir sir will now take the podium.
So that is an end to all the academic fest having being juggled from last 1.5 months by the organizing committee. I, Dr. Satvir Singh, very happy to say that even being a surgeon who does endoscopy and colonoscopy, an odd one out among the pioneer gastroenterologists, have been welcomed on this podium by the organizers, and I'm very heartfelt that such warm welcome given to the persons who do endoscopy, what today Dr. Reddy sir said. So I am very, very thankful to the organizing committee and Dr. Reddy sir for making other persons who are interested in doing endoscopy and colonoscopy to be a part of it. Thank you very much. Now we have a felicitation ceremony for Majid Alam sir, who is a patron to our Jharkhand, and I request Dr. Satish Midha sir to please come on stage and speak a few words about Majid Alam sir.
Good afternoon, everybody. Respected Dr. Reddy, my teachers in the crowd, fellow delegates, ladies and gentlemen. As we all know, Dr. Majid Alam is a retired professor of surgery from RMCH, now known as Rajendra Institute of Medical Sciences. And I had honor of being his one of favorite students. Besides being a good surgeon, he has got a great heart also. When we were third year students, we used to go to his OT because at that time he was one of the fastest surgeons I had seen operating. Because it's not only the speed, the meticulous things which he did, and one of the rarest surgeries he performed, everyone used to come. Though we did not work in his unit, but whenever we knew that he is going to operate such and such case, the whole OT was full. We didn't have facilities like we have today of projections and all those things. Whatever we could see and peep in, we could go and see him. His participation in the surgery seminars and the questions he used to give to us and the explanations and the latest developments and the references for journals were always appreciated by all of us. And he has always encouraged us. Even to this day, whenever he gets information about any of the conferences which is coming up, though he may not be doing these procedures, but he would like to learn what is going around in the world. And I have been attending many conferences with him, and he attends all the sessions, though we are not able to bring all things onto the ground, but his desire to learn, his inquisitiveness still persists, and his inspiration to all. And the Indian Society of Gastroenterology, Bihar and Jharkhand chapter is honored to facilitate Dr. Majid Alam, who has taught many students in this region, and many of his students are working throughout the world. So, thank you very much. Dr. Reddy ko is honor kara le.
BK Agarwal sir already.
I'll request Dr. BK Agarwal and Dr. Reddy to kindly felicitate Dr. Majid Alam.
I request all the organizers to please come on stage for a group. Okay, just a minute. I request Dr. Vijay Shankar sir to please come on the stage.
Good afternoon, everyone. I am Dr. Vijay Shankar, Secretary, Indian Society for Gastroenterology, Bihar and Jharkhand chapter. And again, I welcome you all. We just reaching at the end point of our 28th annual conference of Indian Society of Gastroenterology, Bihar and Jharkhand chapter conference. And it was a pleasure to have our all stalwarts, our teachers, our fellow colleagues and juniors in this conference. We learned a lot from it, and under the organizing chairmanship of Dr. Ramesh Chandra sir, and under the organizing secretaryship of Dr. Manohar sir, and under Dr. Jayant Ghosh, we had a decent conference here. And we had almost around 17 speakers, both from the state and from the country. And also we had more than 250 delegates from all across the state, and also few from outside. And thankful to Reddy sir that we had that opportunity from AIG to have that workshop live, where we learned a lot from it, sir. And your presence here is also a kind of blessing for us. Thank you, sir. And last evening we also had our general body meeting, in which names of the new office bearers were decided by consensus. And we had that new team for the next year. Most likely we'll be organizing our next annual conference in Patna, most probably at Indira Gandhi Institute of Medical Sciences. And I hope it was a enlightening conference, and we all learned a lot from it. And may I now request the organizing secretary, Dr. Manohar Boss, to kindly give his vote of thanks. Thank you.
At first, I would like to thank all of you for patience listening and give cooperation. This was definitely a wonderful experience from our side, because we are organizing for the first time this type of conference, and we definitely learned a lot from AIG live workshop and the talks of different speakers, particularly Dr. Mohan Ramchandani sir. He told me about how to deal with the biliary stricture and the new aspect of endoscopy, particularly Dr. D.N. Reddy sir. So a lot of thanks to all of you for making this event successful. Thank you.
I request Dr. Ramesh Chandra sir to please come on the stage and speak us few words.
This is the last session and it is the valedictory point of this whole CME or this small conference. I know there will be many loopholes in organizing the conferences. If any loopholes or if any problems occur to any of the delegates and speakers, it is our request to forgive me this association. I thanks to our pharma partner, industry partners to cooperate to organize this conference up to this successful. Everything like dinner, gala dinner, lunches, academic sessions and other arrangements for sponsoring most of the parts of this conference. Mostly the Sun Pharma, its all divisions has contributed a lot, and our other major sponsors like Torrent, Cipla, Cadla, Hetero, Alchem, Aristo are all with us in this conference. I also express my greatest thanks and gratitude to all of them. If any name have been omitted, it is not by purposeful commission, it is unknowingly if I have omitted, and I also request other pharma people to forgive me for that. And lastly, I also thanks all the delegates who take a lot of effort to come to this place and spare their valuable time for 2 days. It is very difficult in this time to spare 1 or 2 days for such type of conferences, but your all efforts, dedication and support makes such type of conferences successful. We learnt a lot, we talked a lot, we have a homely atmosphere, we have a cordial atmosphere, and lastly, we are very delighted, obliged and gratified by our esteemed Dr. Sir, Dr. Padma Bhushan, D.N. Reddy Sir, and in one of the newspaper, it was written that धरती का भगवान आज रांची में आया है. इन शब्दों के साथ मैं आज का ये कॉन्फ्रेंस समाप्त करने की आप लोगों से इजाज़त लेता हूँ. धन्यवाद.
Thank you very much, sir. Now I request all the organizers and our esteemed speakers to please come on stage for a group photograph.
हो गया, बस 2 बच्चा हो गया सर, बोलिए ये बजट